Good afternoon. I found my gavel. Uh, Welcome to this public board meeting of Lancashire and South Cumbria Integrated Care Board. As always, I'd like to start by thanking members of the public who've made the effort to come and observe this board meeting, and indeed those that are observing us online through the live stream. Welcome to all colleagues, and I'd like to take an opportunity to particularly welcome Andy Curran to the meeting. Andy is providing interim support to the role of Medical Director during March, further to David Levy, Dr. David Levy, leaving the ICB to undertake the national role. And I know that Kevin, you'll come to it in your report, but we are very grateful for the huge amount that David gave this ICB, and the Nationals' gain is our loss, but we're very grateful to Andy for taking over in the interim. I think that, so then in terms of, oh yes, I was going to do that. I think I will do that now, actually. I was going to do this in my chair's update, but I think it's probably good to get it said up front. There has, of course, been so much that has changed since the last public board meeting of the ICB back in January. Indeed, I've been saying to people when I looked back at the minutes, I couldn't believe it was only 2 months ago that we had that meeting. The national announcement last week regarding the Department of Health and Social Care, NHS England, and indeed ICBs signals a really significant change. The requirement to cut 50% of ICB running costs is a very significant ask, and I know it's caused understandable confusion and distress amongst our staff. I have to say I'm particularly disappointed by the fact that it was leaked to the press before we were given an opportunity to discuss it with our staff. As Kevin said at a staff briefing on Friday, there's still much we don't know, but there are a few principles that we will commit to as we do this work. We will undertake it on the basis of functions. What is it that we are required to do, and what do we need in order to do it? We will work quickly, and we will work as quickly as we can to provide clarity at the earliest opportunity for staff members, and we will share updates as often and soon as we can. I know it's really difficult, and I know that there's an awful lot else going on at the same time, but I did just want to say that up front. Coming back to the board agenda then, Aaron is going to be in attendance for the first 90 minutes, then he has to leave because he is the chief executive of one of our trusts and they have their board meeting as well today. And I've got apologies from regular participant Kath Wally, but the meeting is quorate. And finally, I think that the gentleman who provided the patient's story that we are going to hear later is in the audience, and I would like to thank him very much for coming. It is so powerful when we have the person that gives the story to the board in amongst us, so thank you very much for doing that. Sarah will introduce you later. As always, I wish to maximise our time for discussion. There's a lot on the agenda. And I would ask that executives keep introductions of items brief. Everybody has read the papers in great detail, and the agenda and timings should then allow for good discussion. We've received 2 questions from members of the public. These are in relation to agenda items 15 and 16. They'll be addressed when the items are introduced. The first is from an individual who asked, why is Blackpool Victoria NHS Trust having to absorb savings of up to 50 million forced on them by Lancs and South Cumbria Care Board when the overspend was made by the ICB themselves? And Sam will address this question when presenting item 15. The second is from an individual who provided a personal account of experience with SEND services, which is on the agenda later. Do I have to get my child sectioned to get any type of conversation or input from a psychologist? And how have you failed her and my family time and time again? Round in circles we go in the NHS. Sarah will address this question when presenting item 16. We haven't been informed of any conflicts or declarations of interest. There's a very comprehensive sheet up front. Can I just ask board members, is there anything since those declarations were made? No, thank you very much. Fine. So if we can go to the agenda then. First of all, we have the minutes for approval as an accurate record of the last meeting of the 15th of January. Can I just ask board members to confirm that they are content that that's an accurate record? Thank you. Action log then. I think action 9 is held on the board planner. It's going to come to the May board. And action 10 is also is going to be included within the unscheduled care report later on today. So if board members are happy, I think we can close those actions. Action 11, vaccination update, is also noted for an update to May. So that will stay on the board planner. And action 12, Andy, can you give us a progress update on that? Which is the reassessment of the health inequalities risk score.
Thank you, Chair. So I can confirm that that's been included into the board assurance framework, and then we'll feature through that.
Thank you. Thanks, Andy. Any actions that we haven't picked up? Nope. Fantastic. So we move then to the patient story to ground us in our board meeting. Thank you. Over to you, Sarah.
Thank you, Chair. So before we play the video, just to reiterate your thanks to Gavin and his wife, who are sat at the front row. They might not be staying with us all afternoon, but they have very kindly left some material at the back of the room which relates to Pumping Marvellous, which is the voluntary sector organisation that in particular supported Gavin when you hear his story and his wife. And I think his story also came to Quality Committee, I think it was last month, and you're really, really positive on the video, which is excellent. And one of the things that he says is that once you get into the NHS and the right service, how exemplary the care and the experience has been. But like lots of our patient stories, and when Sheena goes through the Quality Committee AAA later, we did notice at Quality Committee that a common theme throughout is communication or lack of communication or disjointed communication in a lot of the stories we hear, even the positive ones, and sometimes navigating between different services is also quite complex and can be really difficult for patients and families to do. And I think that comes out in Gavin's story today as well. But we'll listen now. He's sharing with us his experience of living with heart failure and then his subsequent treatment for heart failure, and has very, very kindly offered to do further work with us if we want to focus in on some of the messages he said and look to improve them, which I think is really good. So thank you for that.
I'm Gavin Redder, I'm 60, I live in Darwin, and I'm a heart failure patient that's recently gone through a heart transplant. I've had heart issues all my life. I was born with a hole in my heart, which developed into hypertrophic cardiomyopathy. In 2009, I developed arrhythmias, dangerous arrhythmias, which meant that I had to have an implantable cardioverter defibrillator placed in my chest. It was okay until about 2019, and I was diagnosed with severe heart failure. I became breathless. I was struggling to climb stairs. I was lucky that my GP had a specialist interest in cardiology, which meant that he recognised some of the symptoms and started me on some of the treatments, and I started getting the investigations underway. But unfortunately, I became so bad that one night I just had to message my wife, Julie, and say, I just can't breathe, I can't lie down. And so we had to call an ambulance. I was taken into hospital. Whilst I was A&E, consultant cardiologist came to see me and told me that, yes, I'd gone into severe heart failure and that I needed to start thinking about a heart transplant, which was quite a shock, as you can imagine. I started on the treatment, so I got to receive a lot of the important medication that you need to receive. But I also contacted Pumping Marvellous, which is the UK's national heart failure charity, and I got involved with them. When I was initially diagnosed with heart failure, I was in hospital for about 2 or 3 days, and I was told that I did have severe heart failure and I would be referred to the heart failure nursing service in the community. Unfortunately, the referral hadn't been made. So I think communication between hospital settings and the community settings is a bit challenging, really. I think that there could be an improvement on that. Once you get access to the right services, like the heart failure nurse, you've got that specialist advice. But if you see a specialist nurse who knows exactly what treatment you're on and has the ability to prescribe as well, I think makes a real difference. So I coped fairly well with heart failure until unfortunately, in 2023, I had a stroke. And within an hour, I was in A&E and really quickly seeing the stroke nurse was there. I went into CT scan, I got thrombolyzed, and had a fairly good recovery from that. I was only in hospital about a week. Now, when I got discharged from the stroke ward, I was told that that was it. There was no community support for stroke patients, which wasn't correct. And then about 10 days later, somebody from the community stroke team rang me and said, "Oh, you've just been referred to us for a thing." So again, that issue of communication between hospital settings and community settings wasn't there. Everything was okay until towards the end of that year, and I went into advanced heart failure and ended up with atrial fibrillation. And I was told that I would need to have a heart transplant. I need to be referred over to the advanced heart failure service. I was on the transplant list for 5 weeks, and I got a phone call home to say that they got a match. So later that day, I went into Wythenshawe and I had a heart transplant that evening. The key thing for me about heart failure is getting access to that early diagnosis. The sooner you get that diagnosis, the sooner you can start that treatment, and the sooner you can get involved in that treatment. I think it's really important that patients are involved in that treatment themselves. It gives you a sense of control, which I think is taken away when you end up in a hospital setting. Everybody's doing everything for you. And programs like the heart failure at home that are being developed, the virtual ward systems, I think are a much better system that will enable patients to improve their quality of life and be part of that care process. For me, the NHS has been an amazing service. The support that I got once I've got the access to the right support has been fantastic.
Yeah, I'll just to finish, I mean, thank you for being so honest and articulate in sharing your story with us. And I think Gavin said to me before, I suppose from his perspective, what next? What will we do with the things we've heard? And I think it is about real commitment, as I said, to how do we improve communication and joining up services. And I do think the vision we've got about moving more into the community is really pertinent. And we're going to spend some time today focusing on the money, obviously, which is stretched. But again, he made a point that most of the care that Gavin's had could be delivered outside an acute hospital setting, obviously not the transplant, but quite a lot of his other care if we diagnose earlier and treat. And that actually not only is probably a better experience because it's nearer to people's home and it's easier to access, but it's often more cost effective than the treatment that you need once you get admitted to hospital. So I think we need to take, there's lots and lots of things in your story that we will take away, and we will make sure that we underpin the work we're doing with that perspective. And I'm sure Neil and the team will follow up with you on your offer to come back and do some more engagement work with us.
Thank you, Sarah, and thank you so much, Gavin. We talk about the issues that you raise, we talk about them a lot, but there is nothing quite like hearing it as part of a patient's story so articulately rendered, so thank you. And I think what you've said in terms of the services, but also taking forward some of the communication messages. Communication is something that's come up time and time again, and I think we must reflect on that. Do any board members want to come in with any thoughts on that? Yes, Sam.
Thank you, Chair. Nice to see you both again. I think we met at a public event when we were doing some briefings on our vision. So, and I really appreciate you coming today to talk to us and to put your video up. I suppose one of the things that struck me when we spoke at that event, and it's part of your story really, is also the data sharing part of this. And I think you, along with many others, we've heard of how many times you have to repeat your record to everybody in each part of the system. So I think that's an important part for us, and we are looking at that through some of our digital strategy and our data plans. So I think it fits very well with the other things, but I do think it's an important part, that just to give you some reassurance that we are looking at that as well.
Thank you, Sam. Yes, Denise.
I feel like I have to say something because thank you. I know Gavin and Julie. So thank you for sharing that story. I think the other point that Gavin made, which is really important to remember, and I echo the points that have been made about care in the community and where it can be, but the point you made about in hospital, everything's done for you, that's not helpful for keeping people independent and learning how to live with their conditions. So I think we need to focus on that side of it as well for the individual, as well as in the community closer to home is bound to be better for the patient but their family too. So thank you for sharing that. Well done.
Thank you, Denise. Yes.
Thank you. Yes, I want to thank you as well, but I particularly want to say something about what you said about charities, because I'm here really to represent that sector across this board. And I think your experience really demonstrates the importance of us all coming together and working together and making sure that you receive the right care, whether that's delivered through health services or through charitable services. And it was really good to hear that you've engaged with the charity and hopefully still involved with them as far as I could gather. Yeah, thanks, Gavin.
Thank you. Thanks very much, Tracy. Great. Well, you are more than welcome to stay for as long as this meeting is yours, but you may have better things to do. Thanks very much indeed. So I think the next thing then is my report, which is in the pack, and I'm very happy to take any questions on that. I did just want to say a few words, though. We are, as you might imagine at this point, focusing very heavily on the planning and delivery for next year. And board members will be aware that Lancashire and South Cumbria ICB has entered the National Recovery Support Programme. We haven't lived within our means this year. Indeed, as Sam's going to set out later, the system as a whole overspent by over 350 million once we take out the deficit support that's been provided to us. That's over 6% of the budget of 5.4 billion that the system has, and is just not tenable, because we are taking money that needs to go to other parts of the public sector and other systems. It also reflects wider issues in our organisation, which is why we've signed undertakings with NHSE in relation to financial planning, leadership and governance. Kevin will talk more about the undertakings and their implications, but I did just want to make a few observations. And as I prepared for today's board, I looked back at what I said at January's board, and what I said then is just as relevant, even though there's an awful lot seems to have changed between now and then. Firstly, the actions we need to take are largely outlined in our plans and our strategies. We may need some reprioritisation, but those strategies were developed to allow us to fill all four of our core purposes. What we need to do is to get better at delivering against those plans. Secondly, we can only deliver value for money and reduce our deficit by having a very clear focus on the clinical vision. And that clinical vision sets out some of the things we've already talked about in terms of prevention, community services, and reducing our reliance on very expensive acute services. As I said last time, and as I've said an awful lot since, quality and finance are two sides of the same coin. If we provide high quality services, they will be, by definition, efficient and effective services, and we will drive the efficiency improvements we need. And thirdly, we can only deliver our plans if we work together across the system. That means working across NHS organisations, but also with our partners, local authorities, third sector providers who are already around this board table, and most of all, those who use our services. Some of the reasons underpinning our overuse of hospital care across this region are not within the gift of the NHS to sort. Until we work more effectively with others, we won't succeed in doing what we need to do. There is an awful lot to do when uncertainties are around us. And as we head into the next few months of turbulence, it is critical that as a board we keep our eye on the fundamentals of what we do and who we serve. It's equally critical that we maintain our integrity and compassion as we apply our efforts to addressing the problems we face at pace. The scale of what has to be achieved over the next few months is enormous. We'll be going through some of the plans later on today, both in terms of budgets and in terms of commissioning intentions. The executives around this table have worked unbelievably hard over the last couple of months, but it's still work in progress. There's still more to do. But I am confident we can do it, provided that we keep calm, keep focused, and keep working together. Thank you. Very happy to take any questions, including on the written report. Jim.
Thank you, Chairman. It's about the section in your report relating to system improvement. And you're right, we had a very good session where we talked about the need for continuous improvement and the steps to be taken. One of the things we talked about was making sure there was a lead appointed within the ICB. I'm just wondering whether we progressed that or where we're up to on that.
Kevin,
No, we were somewhat taken aback by the announcements last week, and we will take that into account as we work through what we need to do in terms of senior structures and who's good. We're doing a portfolio review at the moment, Jim, but yeah, we still need to attend to that.
and keep on it because it's really important. Any other questions? No, so we'll move to the meat, which is Kevin's report.
Good afternoon, everyone. Probably the main thing I want to talk about is the intervention process, really. We've struggled as a system financially for a very long time. Indeed, in 2019, I think the providers in our system had a deficit of 170 million. And if you go back over the 10 years, that was gradually, every year was in deficit, gradually building up. During COVID, there was a short period where none of the health service was in deficit. We received a lot of monies, but they were withdrawn. Those monies have been used to create extra capacity, and there's been such pressures on the service, it's been difficult to close down that capacity, even though we've lost the funding. So these financial problems are long-term and systemic. They haven't just appeared. They've been around for a very long time. At the same time, being positive about things, there are lots of opportunities to do things faster, better, smarter and cheaper. And indeed, Gavin's story illustrated some of those about how we connect across the health and care system to best effect. So I think it's a really good reminder of that. Sustainable services require sustainable funding, so it's really important that we get this right for the future. And as the Chair said, formally we went into the Recovery Support Programme, NOC4, in December, alongside Blackpool Teaching Hospital, East Lancs Hospital Trust and Lancs Teaching Hospital. As a result of that, we will get some special support from NHS England and from Price Waterhouse, who have been appointed to provide support. We will need to make sure that key decisions of this board, including senior appointments, do have NHS England sign off. And ultimately, if we don't deliver, and it's worth noting this, NHS England do have the ability to remove the entire board. So that's part of this review programme. Now, obviously, we want to deliver as a board going forward. To do that, we've got to make sure that we finish the year well, which I think Sam will be covering later, which we will. We need to make sure that we have a credible and deliverable plan for next year, which we will sign off next week at our board, but we will have a discussion today. We need to make sure we get on top of, within the ICB, continuing healthcare, which is a really big, important service that we fund, but has been the biggest area of overspend for us. And I think we've also got to remember, it isn't just about recovery, it's about long-term transformation. We mustn't lose sight of the longer term, and we must look for all those opportunities to do things faster, better, smarter, and cheaper. I would also just move on from, we do actually, I should say as well, we will be having our first formal meeting with NHS England in May. That's already in the diary. Both Emma and I will be attending that. and that's the formal entry to the recovery support program. They have 3 meetings during the life of that. So you have a sort of an entry, a midway, and an exit, if that makes sense. But moving on from the recovery support program, there are a couple of announcements. I'd first of all just like to thank, on the record, David Levy for his good service to Lancashire and South Cumbria, and indeed the Northwest region as the former medical director for the region. We will be shortly announcing, Andy Curran has kindly stepped in until the end of this month, and then from the 1st of April we've now we're in the course of appointing another interim director to serve for the following 6 months, so I will shortly announce that, and I will also be making an announcement on a turnaround director for continuing healthcare as well shortly, so watch this space, but happy to answer any questions in the report itself.
Thank you, Kevin. David.
Thanks for the report, Kevin. So just two points from me really. So obviously the report talks a great deal about, you know, lots of difficult decisions that are to be made, and clearly that's a time where we want to involve the public much more than perhaps we have done before. So will there be any kind of comprehensive engagement plan to go alongside the changes that will inevitably need to happen, that means that our public is fully engaged and involved in the decisions? That's the first point. And I mean, the staff survey results are alarming in my view. So two things particularly stood out for me. 47% felt that patients were the ICB's top priority. That's incredibly low. And the second one that really stood out was that 37% of staff felt happy with the care that was being provided. You know, I find that alarming and just wonder what has been done to kind of transform that and change that. Thank you.
Thank you, David. Do you want to start? Yeah.
I can do, yeah. So on the public engagement, we've already been doing some. We've done quite a lot already, and probably Sam illustrated that earlier. And I took part in a session in Burnley. So there's already been a fair amount. There needs to be more around, if you look at the wider system where a service is being reduced or closed, there is a process we need to go through before any of that is agreed and enacted, and so there are going to be a number of those sorts of exercises going on across the system, but we've already done a significant amount of consultation and engagement. On the staff survey, yeah, the results aren't good enough. They actually show some significant areas of improvement here from an even lower base. Don't want to pretend that's good enough. What we are doing about it is we have a comprehensive organisational development programme in the organisation. Indeed, I think it was early October last year, we brought all the staff together in a venue in Blackpool to work on this. We agreed some values for the organisation, and there's a comprehensive support programme around that. So we are doing something about it. Having said that, with the announcements last week of a 50% cut in our running costs and our programme costs, that will have a significant impact on the organisation inevitably. So I think, despite all the good work that's been done, we do have further challenges ahead, and it's all the more important that we continue on that path, if that makes sense. But don't expect things to immediately improve. I think they potentially in some areas could be even more challenging because of those announcements last week.
Thank you, Kevin. I can see your hand, Aaron. I just want to say, Neil, did you want to come in on the engagement side of things?
Yeah, I can do. We reported in the last board some of the engagement work that we'd done around understanding, particularly talking about difficult decisions, also talking, kind of teeing up some of the things that you'll see today. So we've absolutely grounded some of the work that Craig will talk about later around the commissioning intentions, around some of the expectations or concerns for the public. A lot of that is around some of those community services that has really featured and been included in the work around the commissioning intentions. I think the key bit now is to make sure, and partly some of what we've described, and it'll be described on the agenda a bit today, but the more robust work that we've done around understanding some of our plans and working more in partnership with colleagues and partners around the table means that we can do some really detailed work that actually relate to changes that make a difference for those people who are experiencing them. So I definitely do think Kevin is right. There will be more engagement that's needed throughout the year. It needs to be really specific and targeted on changes that we're going to make and relevant to those people, and absolutely need to be grounded in the decisions that we make. But there definitely has been a considerable amount of work, certainly before Christmas and in January, and it has featured and been included into the process to develop some of the commissioning intentions, and certainly the work around the transformation priorities that are set out there, which really align to the kind of things that the public said that they really want to see us looking at as a system and an organisation as well.
Thank you. The other thing that I think will help in this actually is when we come to the end of the agenda, where we look at some of the committees. I want more of what is coming out of engagement to come and at the front of the board, and I think that will help this process and the perception of, and also allow us to challenge ourselves on how much engagement we have done. So there's going that will be from the 1st of April. That I think will change some of the board changes. Aaron.
Thanks, Chair. I just think David's question's really important for us to consider, and Kevin's response, I think, is the right response, which is, we know that as a system, for us to improve from where we are now, significant change is required. And with change comes uncertainty and being unsettled, whether you're a user, someone who lives in the communities, or staff that work in our services. I think the ask of us is to be clear on the drivers for the decisions we're making and what the vision for the future is. So what is it that we're trying to change, and why, and what would it be that we're looking to improve over the course of the next 3 to 5 years? I appreciate that right now it feels like a less than and a deficit-based narrative, because purposefully we have to manage within our means, and the cash issue is so constrained. We're having to make decisions that ordinarily we might not want to have made altogether, and in the way that we're making them. So I do think there's something in the continuous dialogue of being open and honest, sharing a vision of the future, but understanding that right now there are going to have to be some difficult decisions that need to be made, and how do we engage properly with that. I can give a lived example. So Morecambe Bay's been on its own improvement journey for the last 5 years, 6 years. This year is the first time we've seen a significant deterioration in our staff survey results, despite continuing to improve, and that's because we've made changes that have impacted on about 1,200 staff, and staff have fed back and said, no, it doesn't feel like a great place to work. It feels really different, feels really uncomfortable, feels really challenging. And I think the more we make those changes, even when we engage, we're going to expect to see, I think, some dissatisfaction in how we're working. And I think as a board, we probably just need to map that out and own it at the start of the process, so we know what it is that's driving this, not as an excuse, not as a deflection, but we can put some proper work around it with partners about how do we best mitigate that. But we can't stop it happening because the changes are necessary. I think it's a really important question David's posed.
Thank you. Jane.
Could I perhaps just add to this point about how we support staff through this really challenging and difficult time? Don't want to underestimate that at all, but there are best practice models and frameworks that you can proactively use to build organisational development interventions alongside managing change. I'm sure you're doing it, Aaron. I just wanted to raise awareness of that. And I think particularly for the ICB, that's something we absolutely have to embed in our approach going forward, so that we are better at managing change and supporting people through change, and drawing on best practice to enable us to do that in a really quite systematic, proactive way. And that's something that I can look at through my people committee responsibilities.
Thank you. Thanks very much, Jane. Tracy.
Thank you. Yeah, I just want to pick up on a few of the comments that have been made around that kind of longer term view, Aaron, that you made, and also thank you for your honesty, Kevin, in your report around those kind of difficult decisions. I think one of my concerns, and something that colleagues have been talking to me about for a number of weeks now, is we recognise in the PCFSE that the difficult decisions need to be made, and that there's going to be an element of pain barrier that we're going through at the moment. But I think it's just a kind of a word of caution around some of the services that we potentially could be losing as we go through this process. And I'm thinking particularly around colleagues in the hospice sector. I'm hearing an awful lot of really significant concern around some of the virtual ward provision, some of the hospital to home provision that potentially we could lose in the short term because of this financial situation that we're in, and how that will leave us in a position where actually we're moving away from some of those longer term goals around prevention, around more care for people in the community. And it's how we mitigate some of that risk. I was going to pick some of this up under the commissioning intentions paper as well, but I suppose a bit of reassurance really from yourself, Kevin, around how we make sure that we mitigate from unintended consequences, but also that we do take our time and really understand the decisions that we're making, and not just make them as short-term decisions, but actually think about that long-term impact, and the fact that sometimes when services go, they are almost impossible to mobilise again.
Thank you, Tracy. Kevin.
Yeah, really good point. It's been a challenge for the last couple of years. Really want to stress our response to recovery support is recovery and transformation. It's not one or the other, it's both. And there is a balance between the two. And sometimes, as Aaron said, you do have to make some decisions you don't want to make. But I think in the area you've picked on, this is actually one of the ones that actually works both ways. So I think when we look at the uplifts for this sector and the plans we've got for the future, end of life will be a critical area for us. It happens to be, I think I'm right, Andy, in saying there's nearly 600 beds equivalent in the hospital sector with patients who are within 4 weeks of dying. Many of those are planned deaths in hospital. It'd be far better to be in a hospice environment or in a sort of hospice at home environment. And actually, if we get this right, this is a way that doing the right thing for the patient, improving their experience and that of their family around them, actually also works financially as well. And that we need to do much more of that going forward. So this will be one of the areas that we are focusing on going forward. And I think it's potentially a win-win for us. And it's also an area where we would be doing it with the not-for-profit sector going forward as well. So I think you picked on one which is actually exactly the sort of one we need to focus on going forward.
Sam.
Yeah, I just wanted to add to that because I think it's really important. And when you're talking about difficult decisions, but actually some of these are just decisions that are the right thing to do as well. So when we're tying together the financial transformation with the long-term transformation, it's really important that they're doing it in the right way. And one of the things that we've just been talking about is those engagement events that we've done already with the public. They have helped us shape the vision, and we're using that vision for our transformation, and then we're aligning it to the aims and what we're trying to do for our population, and then putting that across with what we've got to do in terms of delivering the plan. When we do all of that, that's what's driving our commission intentions. So we shouldn't be making decisions that are wrong. And one of the very, as you say, like a very real example in the last week that the execs have looked at is some support for the hospices. And we've looked at the uplifts and we've looked at what we need to do to support them, because it would just be, you know, the wrong thing to do to look at an area like that, because that will just cause massive cost pressures elsewhere in the system anyway. Not to say it's not even it's the right thing to do as well. So actually we are trying to make sensible decisions. I wouldn't like people to think that when we're talking about difficult decisions, where they're like slash and burn, we are not doing that. We're trying to make these in a measured way and trying to make it right for our long-term strategy. Because if you think about the plan, and I'm going to talk a little bit about this in my paper, but the plan that hasn't quite worked this year, which is why we're off plan, was driven by quality. It was driven by trying to reduce corridor care and escalation beds and other things in A&E. But to do that, we need everybody wrapped around it. And it's worked in little parts of the system, but not wholly. That's what we need to get right to get out of this. We're not going to get out of it overnight, but we're trying to do this in a really measured way. And with transformation, as Kevin says, has been a big part of it. And the public engagement is already feeding into that, but we need to do more of that as we go forward.
Thank you. Thank you very much. Thanks, Kevin. Okay, so we now move to the People Committee escalation, which follows on very nicely.
Thank you, Chair. This committee met just after we'd gone into intervention, but before the Pulse survey and before the recent announcements about staffing. So it feels, you know, out of date already. However, that said, we did talk about the enhanced intervention and actually had a really constructive conversation about how staff were feeling across the system, about the levels of fear and uncertainty and how dissatisfaction and poor morale and so on, and kind of what we actually did was just acknowledge some of that. And I think we did a really good job actually just acknowledging, didn't we? Because it felt like almost there's not enough of that going on. There's an awful lot of talk about difficult decisions and a kind of rational approach to this, but also there is something about just accepting how it makes people feel. This is not what they signed up for in many cases. And so we agreed as an action that we would do a deep dive further into that kind of health and well-being impact right across the system. It's not just for the ICB, of course, it's for our providers and other sectors as well. But since then, of course, we have had the Pulse survey and we have had the announcements about the reduction in staffing. So the points I made earlier about doing the best we can with this are even more important, I think. So I think this is something where the People Committee needs to take the lead going forward from that kind of well-being perspective. The other point about it, though, possibly, is that there is an opportunity. If you look at some of the themes coming through the Pulse survey, they still seem to suggest that staff are not sure about the organisational vision and where they fit and so on. And it is an opportunity to address that. So I'm not trying to be too Pollyanna-ish and say there's a silver lining, but actually some of the things we can still address, and we should take the opportunity to do that. The People Committee, in terms of assurance, thanks to Debbie's work, we've got stronger governance arrangements. So we had a series of working groups that's now been replaced with 2 subcommittees which are more formalised. One will have an internal ICB staff focus and the other one has a kind of external system-wide focus. And I think that, and they will feed into the main committee, which will strengthen those governance arrangements. We formally approved the gender pay gap report, which always seems to say the same thing every year, which I can talk more about, and says the same thing for most public sector organisations. You know, we just need to keep mindful of that and do what we can. And we also took reports on freedom to speak up. And lastly, we did the work that is going on. I do want to commend staff, particularly in Debbie's team, for all the work that is going on around culture and values. You know, there is more to do, but there's an awful lot of work going on, and I wanted to thank colleagues for that. Happy to take questions, Chair.
Thank you, Jane. Any questions for Jane? Yes, Sarah.
It's a comment more than a question. I suppose as listening to Jane and the comments Aaron made before, I think it's also really important. It is about staff wellbeing during this really difficult time, but actually it just triggered a thought with me. There's a really hard evidence, and the Institute for Healthcare Improvement in particular with their Joy at Work focus, that morale among staff directly impacts on outcomes for patients and care. So this isn't just about managing that from a morale, which is really, really important. I think in these really challenging times, all of which we all understand, we need to make sure we are triangulating, you know, the difficult decisions, but also that we're watching that staff morale, because it does directly impact on care, because we know that there's reams of evidence about that. So it's quite a challenge for us as leaders, how we get that balance right. But we need strategies that aren't just about morale and well-being, but actually how are we making sure that we're supporting staff through, and it isn't allowing standards of care to slip.
Thank you, Sarah. David.
Thank you. Just, I suppose, just to come back on a couple of things. I mean, the base is low already, isn't it? We've got very unhappy staff already in the system, and we're now going to make some decisions that are going to make things even worse. So I suppose, I think isn't it our duty to kind of see what the plan is to make sure that we address that as we go through the coming months. We should be assured that enough activity is taking place, because, like Sarah, you've just mentioned, if we go from the low base to an even lower base, then patient care is going to be affected. So I don't know, for me, I would want to see some kind of assurance that there is a very, again, a comprehensive regime of things going on to address how staff are feeling and help them feel better.
Thank you, David. Debbie.
And I think not only not only for us, our staff, but also for our managers and leaders. So the governance structures that we've put in place now, which will be external focused as well as internal focused, help us in terms of keeping an oversight of that. What we are doing also is developing a 12-month people plan based on the strategy that was approved last year. That needs to be updated given all the recent announcements, but that's how we will monitor impact. And the point around triangulation is a really well made point in terms of, you know, we can look at these single metrics, but if we don't understand the impact in terms of the service provisions, it doesn't mean anything. But I think we really should be open and face the fact there will be some detriments in terms of the measures that we are currently measuring. We've seen some tremendous improvements in terms of the ICB and also in some of the providers. But given where we are, given the announcements, given the uncertainty, I don't think, you know, it'll be unrealistic not to think of that there will be a negative impact on that. And I think all we need to do is continue the engagement, which we have started, asking our staff for feedback, asking actually them what can we do to support them, and seeing how we can accommodate their needs. I think that's what we will do and continue to do. And I know the providers as well as the ICB have begun that work. Thank you.
Thank you, Debbie. Kevin.
Yeah, I think just to round off this discussion, I mean, Emma and I went to London on Thursday to hear the announcement. We were told we were getting a 50% cut by Q3. That's quite fast. That there would be a national redundancy scheme. This is not Mars. This is going to be redundancy. That would be coming out very shortly. That our role is about strategic commissioning first and foremost, and that we need to reduce the oversight role. We're not clear at this stage whether there will be any legislative changes, because we have legal responsibilities outside of commissioning, quite a lot of legal responsibilities outside of commissioning. That news was leaked to the media before the Thursday event. We arranged a session with staff, which I led on the Friday. We had over 600 staff at that session. And I think it was really important to say, actually, this is what we know, but there's quite a lot we don't know. So I think it's really important during this that we're honest and transparent throughout the whole process, but it's going to be difficult. It's absolutely going to be difficult, and it is going to impact, and that's why we need to be doing more in this space going forward, and it needs to be front and centre, but it is definitely going to be bumpy along the way. But our commitment as a senior team and as a board is that this is going to be top of mind, and we expect it'll feature in my reports going through, and that we will take it very seriously, but it is going to be challenging.
Thank you. An important discussion. Jane, can I just ask one specific question around freedom to speak up? I think that's a really important service. One hopes it's only used. One hopes it's part of a whole range of opportunities to speak up. But in of itself, when you've got a lot of anonymity and a low take up, that is a cause for concern. Is that? Can I just ask what the and it may be a question to Debbie actually, but what's the plan, I guess?
We have been doing a lot of work trying to raise awareness with staff and encourage them to speak up. So we have two excellent guardians, Sarah and Rachel, and previously David was the executive lead and so on. And if you look on the website, it's one of the buttons you see first. We're embedding this in staff induction. There've been awareness sessions, trying to encourage staff to speak up. Now, the uptake is low, but it's always difficult to know whether low is a good thing or a bad thing. Do you know what I mean? It could be low because there's not much to speak up about, or it could be low because people are not using it. And it's quite hard to measure that, to be honest. But there've certainly been enough instances where people, and the kind of issue, sorry, just to go back, freedom to speak up initially was set up, I think, in the NHS around clinical patient safety matters. What our staff use it more for is around management issues and staff welfare and their kind of HR type concerns, actually, where they haven't found a vehicle to express that differently. So we are providing a very useful role where people are not sure of the way forward to resolve those issues. And I'm assured certainly that it's providing a valuable sort of route. It may be that people are taking other routes, and again, that's hard to measure. You don't know what you don't know in some instances. We've talked about this quite a bit. I would be happy if there were more cases coming through, and actually I think as we go forward with this, if freedom to speak up is a vehicle that can be of more help, that would be a good thing. So we just need to keep encouraging people to use it, I think.
Debbie?
I suppose one of the things is that one of the positives is that from our pulse survey, we know that 82% of our staff feel that they are well supported within their teams, which is positive. I think the small number of people that feel unable to put their name to their complaint is a bit of a concern, because we are not unable with that to look into the concern more, in more detail. So it is something that we did discuss at the meeting, didn't we, Jane, around how we can create, and it goes back to the culture work, around us creating an environment where people feel psychologically safe to raise those concerns with their names in order for us to look into it in more detail. There will always be people who won't, but I think we want to sort of do as part of our culture work, create that environment, and that's, again, will be coming back as part of our ongoing reporting.
Thank you. Chris?
Thank you, Chair. Debbie's just covered it. I was just going to bring up around that psychological safety, and it's the cultural piece, I think, with freedom to speak up and the other routes that colleagues have to raise concerns. But it's been made.
Thank you. Thank you very much. Okay, I think we will move on. Developing to the next section, which is called Developing the System and Strategy. And as I said at the start, I would like to pay tribute to the enormous amount of work that the execs have undertaken on this. You'll see in the end paper the number of board meetings that we've had on this. It feels like we've only moved out of one when there's another one, and we're driving the pace. But this is still work in progress. So we're not looking for final approval here. This is endorsement of work to date and intentions. That said, I'm going to hand over to Craig for Commission's intentions process.
Thank you, Chair, and welcome. Good afternoon, everybody. So this is the second time I brought Commission intentions to the board. This paper is slightly more detailed from a process perspective, and that's because we have adopted a new process this year. So I thought it was important for both board members and members of the public to see some of those changes. But I'm going to assume everyone has read the paper and just concentrate on the highlights. So this is a fundamental component of our wider system planning, and I just emphasise the word system because it's not just about the Integrated Care Board's intentions and what the Integrated Care Board wants to deliver against its vision or strategy and what it wants to purchase. It's a whole system approach, and our partners have been involved in the Commission intentions since we commenced this round in last September. The difference for this year in relation to how we've approached the refinement of the Commission intentions is the three-staged approach we've had, which is about engaging first of all, so learning from previous years. The first year we didn't have the opportunity to do that as it was our first year, but we've been able to do that this year and look at where some of our strengths were, but also some of our areas of weakness and how we can improve on those. That's been across our acute providers, place, and with our population. The second is about that analysis. So what is the information and intelligence telling us about how we need to commission differently in the future? So examples are right care, our NHS benchmarking, etc. So we've really wanted to make sure that that's been built into the process. And finally, about prioritisation, and we have adopted a new prioritisation process, and you'll see in page 6 of under table 1, we've gone along the lines of strategic alignment, impact, cost, complexity, resource capacity, etc. And therefore each of the Commission intentions has been through that rigorous process. The other new additional element is we've now started to segment our commission intentions into 4 segments, starting with segment 0, which relates to our contracting work with each of the providers. Segment 1 is about where our providers can take decisions bilaterally, either with the ICB or other specific trusts, and we're empowering our providers to move forward, to look at opportunities for that particular organisation. Segment 2 is split between providers and ICB. This, I think, is one of the most important segments. So this is about our transformation as well as our improvements, and where it requires collaboration on a system footprint. And then finally, segment 3, which is a more medium to long term, that's with regards to our reconfiguration intentions and links to our Lancashire South Cumbria 2030. So I think Sam mentioned earlier, this is about our transformation of the future and ensuring that we don't just focus on concentrating on today. Just to give the board assurances, there are detailed line by line descriptors in each of those segments on the commission intentions, but what we've provided for the public and members of the board is a summary of that in the documents attached. The other elements that I think are just slightly different are how we're going to mobilise and monitor this into delivery. So you heard me mention just a couple of moments ago some of the challenges or weaknesses, and I think part of those had been how we implement this into our delivery with our commissioners and our organisations. So we've taken a new approach to that, and I will be bringing back to board in April clear deliverable plan on measurable milestones and measures of success. So we're taking a different approach to delivery this year. People might recall from the September board, only 50% of our commission intentions from last year had started to be implemented, and actually we want to see a much higher result on that. The board asked for, under section 7, us to include our unifying goals, so we've included those as a part of our improving population health. So there's 3 goals there, and I wanted to ensure that they were absolutely baked into the commission intentions. As you mentioned, Chair, this is a work in progress, so I'd like the board to note the work in progress. Like to note and seek any comments on the population health elements for the unifying goals, but also to endorse in principle the commission intentions. And I've included the draft document that's not gone through our communications and engagement process yet, but will do post this board, due for publication on the 1st of April, and I'm happy to take any comments on that. Thank you, Chair.
Thank you very much, Craig. Oh, lots of hands. So I've got Saxi, Aaron, Jim, David, Chris. Better write those down. Saxi.
Thank you, Chair. Thanks, Greg. I'm reading the documents, reflecting on it with the Director of Public Health role on for which I'm here. A couple of questions. One is, clearly the commissioning intentions are aligned with the situation our system is facing, and particularly in terms of the recovery support programme, and specifically about reducing the funding to services. What, if any, public consultations might be involved in this? Was the first question. Second one is, it's really good to see the population health unifying goals. What would be even better would be to see how our commissioning intentions are either supporting or will be challenging to achieve the unifying goals, so that we can be clearer about having a goal is one thing, but the actions that we are undertaking, how it's impacting on that. I think it'll be very pertinent, especially given when there is a lot of focus on finances. We can't take our eye off the quality and the inequalities that we also signed up to and have a duty towards. So thank you.
Thank you, Saxi. Greg, do you want to, I think if we come back, I think, because then I think we'll have a more rounded conversation.
Thanks, Saxi. So there potentially might be elements where particular services might require consultation. We have a very clear process now where it's reviewed and gate kept by the ICB. There's engagement with NHS England on major service change, and then there's consultation and discussion with the provider. We also engage with the scrutiny chairs and with our partner members, and we've got a couple of examples where we've done that recently very well, and actually we've made those changes. The ICB, NHS England and scrutiny didn't feel that consultation was required. I would, however, envisage that as we go forward, we will need to consider that, and some will trigger consultation, and obviously I would need to be bringing back to the board and keeping them up to and abreast of all of those potential impacts that do require a more detailed and a formal consultation process. And on the second one, you're absolutely right about the elements in relation to the goals on the delivery, and they will come back as a part of our delivery plan. So we need to put more granular detail around that, the who, the what, the when, the why. So that'll be something we'll be working with you on in the future.
Great, thank you, Saxy. Aaron.
Thanks, Chair, and thanks, Craig. It's just a recognition, as you have, Chair, of the amount of work that's gone into the Commission Intentions piece this year. It's reflected in the document, also, I think, respected by partners. Two comments, if I can, Chair. One is, whilst it's a staging post, there are only 6 working days to go before we have to submit final contracts and income positions for this year. We haven't yet reached agreement, so it's important that we get that kind of locked in. It's quite a transactional point, but it's important given that we can then move forward with delivery. Conscious there's still bilateral discussions happening even now with providers that we just need to land. I'm going to come back to the point that I made an earlier part of the agenda, Chair, which is the connection to the vision and the story in the system. I can see the unifying goals, but we've got that overarching imperative, haven't we, around reducing population health, living within our means, reducing health inequalities, and ensuring that kind of the integrated pathways that we're trying to develop are delivered. I think you can see lots of that intention in the Commission intentions, but it's not quite weaved in a way that would allow us to stand in front of communities and partners to explain why this year is going to be another progressive year towards that vision. I think it'd be really helpful to have an overarching piece, even if it's just a slide or a paragraph or two, that just says this year is the year we make inroads into these elements and this is how we're going to do it.
Yes, thanks, Aaron. You want to
Just very, so I agree with Aaron. There will be letters coming out to our providers imminently, Aaron. So absolutely take that point on. We do need to reach agreement quickly. Regarding the vision strategy, the challenge has been, and you'll see I've got another paper on the joint forward plan. I've brought papers on the integrated care strategy. We've got our strategic objectives of an ICB, and we've got an emerging 10-year plan. They don't all knit together nicely or neatly. However, we've got a responsibility to our public and everyone to make sense of them. However, I think your proposal, because these are draft intentions, the whole point is we receive feedback from board today, we can add that paragraph in to the published version that we're proposing to publish on the 1st of April. So I'll take that offline just to make sure we capture it properly, Chair.
Great, thank you, Aaron. Jim.
Thank you. Couple of comments really. First one is to say I think it is a very good piece of work, and I think we should know that there's a kind of a really good structure to what's being produced here, which is kind of repeatable in years to come. So in that sense, I think it's really good. I also recognise it's a work in progress, and I think we're all I wouldn't say looking forward to, but the next stage where we get the kind of the financial implications of this is really important for us as a board. So just to note that. Just on the finance side, I do notice in the paper, which the second part of this, it refers to the deficit of being £350 million this year. I think we've had a conversation earlier where that's the underlying deficit, and we just need to make that explicit because that will not be the reported figure for the year. The prioritisation bit, you mentioned prioritisation. It's interesting that in there that the cost accounts for it's 20% or something. It's either 15 or 20%. In reality, at the position we're in, the affordability is kind of like, I wouldn't say it's 100%, but it's more than half of the conversation really. So saying finance is, or the cost is 15% at this point in time is kind of not necessarily right. I think that's what it would be if we were doing a comparison between schemes basically, but in isolation it's not 15%. And I do support the unifying goals. I think it's good to see those in there. The one thing I would say though is when we had the conversation at the board development day, the first one, which is about reducing the gap in life expectancy, we said we'd do that in 5 years. It's now gone to 9 years, and 9 years kind of almost kicks it into the long grass. 5 years concentrates minds, and I don't know whether I recognise that you're saying here it's in line with the NHSC goals. Whether we need to agree some interim goals on this, as opposed to if we're not going to do it in 5 years, whether we can agree that in 5 years we will have done such and such a thing. It just feels too long basically for such an important thing for us to be addressing. Thanks.
Thank you, Jim. Craig, you might want to bring Saxy in on the
on the goals.
On the goals.
Yes, thank you, Jim, and thank you for the kind comments. There has been a huge amount of work. I just do want to say this has not just been commissioners or executives. Our PMO office, Alex and Charmaine, have worked tirelessly on this, and I think it's worth a public shout out because they've worked extremely hard in producing this. I'll make sure the underlying deficit element, I'll work with Sam to make sure that that's documented properly, and I would have to defer if Andrew Bennett was here as the Director of Population Health to him on those, because I wasn't in that session, but I don't know exactly you've got a view on our unifying goals being 9 years away. I think it sounds sensible what Jim's proposing in relation to interim goals, but
Thank you, Chair. Thanks, Greg. I think it is important to have the goal and to specify that. I've seen Chris's organisation also having the health inequalities focus, so there's an alignment here. I think the knack would be to work backwards and appreciate that actually the gap is widening in Lancashire. So to even stand still is going to be challenging, and to commit to 50% reduction has got a lot of implications in terms of where we focus and so on. So I'd be advocating for really zooming in on where our focus is going to be, as small as it might be, but will have a bigger difference over time. So it could be populations like populations at risk of having heart attacks and strokes. Can we just lean in on certain communities? Early years, it will take 30 years, but in 3 years we can see a difference if we really focus on the first 1,001 days. So I'd be advocating similar initiatives and work with Greg and Andrew on.
Thank you, most helpful. Hang on, I'm going to go back to my list. David is next.
Thank you. So my question relates to point 6.3 in the report, where we're talking about the health and inequalities impact and risk assessments, and I was left wondering whether or not there's an opportunity for people, the public, to be involved in that process, and if so, how might they get involved, so that I guess the ICB and the system isn't marking its own homework. We need a level of independent scrutiny on the decisions that have been made, and also the impact that might have on people's on health inequalities. And certainly, in order for Health Watch to carry out its statutory role, we would need to be involved in that process in some way.
Great. Oh, Sarah, sorry.
Well, I had 2 points to make, and one of them I was going to refer to section 6.3, so I will answer David's, and then
Excellent.
Can I make my second, please?
Please.
Yeah,
Yeah.
it probably flows on. So I think what I was going to flag was, I think the way the paper was written, it almost implies that Quality Committee are seeing all the QIAs, and that's actually, as you know, Dave, because you sit on Quality Committee, not the point at the moment. But and also Joe, who comes to Quality Committee, had flagged that point with us to raise. So in answer to your question, yes, we've already agreed in principle that for the relevant QIAs where they would have a wider system impact, that we would draw on partners like Health Watch and the voluntary sector to have a look at some of those QIAs, but being very transparent. That's been agreed in principle in terms of the process we've agreed for QIAs, and I don't think we've yet figured out quite how to do that in practice. So that is something that I'm working on with Alex Wells in the PMO in the background, with a lot of input from Joe Hannett advising us on how we best do that. So and I'm happy to pick that conversation up with you as well outside, David, how we make sure that we bring Health Watching. So that is the intention. I think in terms of the QIAs generally, Quality Committee has overseen the development of a policy. We've definitely improved as an organisation in our approach to QIAs and how they're embedded in the PMO and the commissioning intention process. What we're still working through is how Quality Committee gets the oversight that's alluded to in the paper. We just haven't quite got that working as the way it needs to work yet, but that is all in train. However, I can assure the board that all the QIAs that are completed do come to myself and Andy now, as Andy's seeing, for a final review and sign off. The other point I wanted to make, if I may, it's on the goals, so I do support them. However, I wanted to draw board's attention to the AAA from Quality Committee when we get to it later, and David will remember the discussion, I'm sure, because it was David's challenge. So at Quality Committee, we do quite a lot of overview of the LEADER programme, which is the review into mortality, and when somebody with a learning disability dies in one of our NHS settings, we do a review of their death and any learning from the death. And this is a national programme, and it's aimed at driving improvements in mortality and morbidity in people who live with a learning disability and or autism. And unfortunately, we're not not shifting that dial either, Sackby, at all. And what Quality Committee felt quite strongly, we do a lot of oversight of learning disabilities and autism at Quality Committee, including SEND, which we'll come to later, was that actually knowing that board were wanting to set goals, that could we not have the board's commitment to have a specific focus on our population of people who live with a learning disability and or autism, because they are often lost in our communities, or they are often they're the people who are often really hard to reach into services and get the support that they need, and we're definitely not seeing improvements in outcomes. So that ask is on the AAA from Quality Committee, so I thought this was a good time to flag that to board. Thank you.
Thank you, Sarah. What have I got next? Sorry, just a minute. Chris, and then Debbie.
Thank you, Chair. So it was Aaron picked up the point around the contract values and nailing those down, and we need to get into the detail, I think, around some of the intentions so that we don't have further roll-on impacts. I thought it was really good to see, though, that there are some of the conversations we've had around the board are being picked up in the commissioning intentions, such as the neurodevelopment pathway. It links, and it'll links to the SEND later, and that right to choose. But really, I just wanted to take, we had a discussion at our LSCFT's board around when commissioning intentions are really impactful and when they hit. So we had, 2 years ago, there was commissioning intentions around increasing access to mental health support. And through that, we initiated the initial response service, which is one call for anybody in the community. Since that's been initiated, we've seen a 25% increase in access to mental health services. And since that time, we've seen a reduction in suicide for people that are access to services. That's a massive impact on those families that's impacted. So for me, I think working commissioner and provider is just so important when we're talking about commissioning intentions, to make sure there's no unintended consequences, or the things we are focusing on are the right things. And there can be a decision for good, rather than we're talking a lot about difficult decisions and reductions, which is absolutely where we are as a system, but we can make some really good tangible changes.
Thank you, Chris. Very powerfully said. Thank you. And finally, Debbie.
Thanks, Chair. So it's 2 points, if I could please. So the first one, first of all, it's a great piece of work and can really see how it's moved forward, Craig. So just recognising that and the work of the team, and also in partnership with others, because it's system commissioning intention, so it's got that dynamic. The first point is just reflecting back on Emma's points at the start of the meeting, that the priorities for us need to be on both funding and living within our means, and also quality. So I'm just wondering, when this comes back to us, can you give us assurance really that we'll be able to see both aspects coming through? Because it's really important that as a board and also our public can understand when we're commissioning something, that not only is it being done in an efficient way, but actually it's making things better or moving us forward in terms of outcomes and impact. And then the second point, if I may, it's back to paragraph 6.3, Sarah and David, but from a slightly different lens. So you've already picked up the point about how important it is that engagement and involvement's baked in. So not just where there's a formal consultation, but that we're doing it intrinsically whenever we make decisions. I just wanted to understand better, because it mentions that we won't always do an inequalities impact assessment in the report, and I just wondered under what circumstances we might not do that, just so that we could get assurance really that if an assessment isn't done, we're picking that up as a really important priority in other ways when we're making those decisions.
Thanks, Debbie.
We actually do. So again, I think that's where maybe that's not worded, because the way our stage 1 process for any schemes that are being worked up, it asks for an EQIA and a QIA. Some organisations have them as one form. We have them still at the moment as 2 separate processes, but we do ask the team to do it. I do think we are better at doing QIAs than we are doing EIAs, but it is built into the process.
So it's not, so when it says we're recommended, it's that it's always recommended and it's always done.
Thank you. Do you want to pick up on the quality, the sort of outcomes, what we're going to see, I think is what she's getting at. Yeah.
And that links to the delivery plan that I've described. So the measures of success need to look at what have they achieved the intended outcomes? Has it made the improvements that we expected? Has it lived within its means in relation to finances? Has it also added value, and what the patient or member of public or residents experience has been? So they'll all be part of how we assess whether or not that commission intention has had impact in the right way.
And that will be set out when they are for approval, so that we've got how we will assess them.
Will come to the April board,
Yeah,
as a part of the delivery plan. It'll be, we might not call it measures of success, but it'll be those measures that we need.
Yeah, great, excellent, thank you. And I've got Sheena. No, Jane, sorry, Jane, then Sheila.
I'll be brief. Just like to echo the same comments about thank you for this piece of work, and also because it's developing, we feel part of the process, which is actually quite nice. Table 1 looks at prioritisation, and I've been looking at that and trying to work out whether that would give us the right answers. And I'm not sure it would. I think, just in terms of my initial response to it, I think strategic alignment is too broad. I suspect we could put everything against aligning against our strategic objectives. So we probably need to be more granular on that one. And some of them I'm thinking effort. How do you manage effort? And if it overlaps with complexity and capacity, how do you differentiate them? So I think it's a really good start. I mean, picking up Jim's point about cost as well, is that in the right place, and is cost the right word? But I'm not sure we're kind of there yet. I think that probably needs a little bit more work. I'm loath to offer to help because I'm certainly not an expert, but I would be happy to try if that's helpful.
Thank you. Craig, do you want to come back?
Yeah, just to say that, that there's no exact science to this. So you're right, we will be trying and testing this model out and probably refining it further. This has been a model that's been adopted elsewhere, I believe, and been successful. So, but I don't think that means automatically it will be here. Maybe not for Lancashire and South Cumbria. So we will keep that under review and bring back any proposed changes and the reasons why in a future board meeting. Because I usually update, as I've said, September, October to the board formally on a mid-year review of commission intentions.
Great, thank you. Thanks, Jane. Sheena.
Yeah, it was just really about bringing this to life in terms of how we translate and transact it. And also then linking back to the last item on the agenda, which is about the review of committees. So people will be aware in that paper, we're talking about the quality committee becoming a quality and outcome committee. So in terms of that assurance around is, are we seeing those dials changing? Where are we going to look at that? As an organisation going forward, that's really where that comes into play there. So I think it just be really positive as we move through the year, just to test out how we're doing that. If that's what the outcomes we wanted from these things, that is our opportunity to really scrutinise that as a board. So I just wanted to give that link really for people, so people can then see what might be a bit of an abstract paper at the end of the afternoon into, well, where does that link back in? Thank you.
Thank you, Sheena. Really helpful. Good. So thank you, Craig. I'm going to ask the board to note the approach taken. I think we note and value. Sorry, Kevin, did you want? No. We note and value the approach taken. I think we're supporting the 3 proposed unified goals, noting that further work needs to take place around, particularly, I think, the delivery about them. And we are asked to endorse the commissioning intentions, as well as, so which we do, and endorse being different to approve at this stage. Thank you. Thank you very much indeed, and a really good discussion. Okay, so we're now still with you, Craig, review of the Lancashire and South Cumbria joint forward plan.
I think I've got a few more spots as well on the agenda. So thank you, Chair. So this is a requirement of us to review and republish our joint forward plan. So board members will recall that we published this in 2024. It was due to be published in April. However, due to the pre-election restrictions and national guidance, we didn't publish it until July 24, and then it needs to be refreshed every year. We thought we might have until July this year, but they wanted us to do it before April. So in line with national guidance, this is what we call a light touch review of the JFP. So this is about just looking at the 25-26 position, and it's allowed us to look at it in line with our priorities and assumptions. So what it's resulted in, and I've attached this to the board members, is an addendum to the JFP that sort of provides that public facing overview of our plans and intentions. So can very much be linked to both the roadmap for 2030 and our commission intentions, but it does draw upon that vision and acknowledging some of the achievements that we've had in the previous 9 months. We are expecting a 10-year plan. We're not sure whether this will replace the JFP or whether they'll ask us to include the JFP in relation to the response to the 10-year plan, and we don't actually know the timescale. So as far as we're working on, this will be our joint forward plan for 25-26, aligned to commission intentions and aligned to our vision, and I've attached the plan for any comments or questions. Thank you, Chair.
Thank you, Craig. Any comments or questions? Jim, Saxy, Tracy. Jim.
Yeah, overall, I think it's very good, by the way. So I think it's good. The comment about the deficits also in here, but the point I wanted to raise was just around the digital and data strategy. We are still expecting something to come back on deliverables on the digital and data strategy, and it would be helpful if in this paper it actually explained what is going to happen at some point during this time. But it's so vague. It doesn't commit us to do anything really, and you know. Every time we have a patient story, for example, we talk about the need for greater communication and for removing some of the problems around the fact that parts of the system don't talk to each other. We should be seeing some of that reflected through the digital and data strategy. And if we were seeing that, we could put it into a document like this and almost be committed to doing things. So I suppose it's a request to see some actual deliverables associated with the section on digital and data strategy.
Thank you. And of course, Asim is not here. Fine. So I think it's a point well made, Jim, and we will take it away. I think the sensible thing would be to bring it to a future board digital and data strategy. Sakti.
Thank you, Chair. It's an extension of a similar principle about that this is an annual plan, and I'm only raising this because there is a requirement for the health and wellbeing boards to support this joint forward plan every year. And there are more than one board, so it would make its rounds through all the boards. It might be really handy to have a table or a diagram to show the markers of success and how they relate to either our performance framework or the priorities, just to build on what Jim was saying. So at the end of this year, we can say providers and the ICB have signed off this joint forward plan. How have we done it? So other people can easily refer to it. Otherwise, they'll be scrutinizing and spending a lot of time, and also we may not be as a board able to describe clearly how we've achieved, or what success has been achieved. Thank you.
Thank you, Sakti. Craig?
Yeah, so there's very specific guidance. So this is not requesting the health and wellbeing boards to sign off the plan because they've already signed the plan off. This is a light touch refresh that requires us to share the updated priorities for year 5 of the plan, which is what we've done. So we will be taking this to health and wellbeing boards and sharing with NHS England, but it's a rewrite of the plan requires us to re-engage on the plan and therefore then re-sign the plan off through health and wellbeing boards. So there's a slight nuance that we checked out with NHS England in doing this light refresh, and I would imagine what we'd want to do is take the 10-year plan response through our partnership boards, but it will be going to health and wellbeing boards to receive as a part of the process.
So what we're saying is this is an interim update on request, but when the 10-year plan comes out, we will need a new.
Whatever we need, I will take to the right
and that
partnership
will need to be
boards.
done
Yeah.
properly through the health and wellbeing boards. Yeah. Okay. Thank you, Tracy.
Thank you. Thanks, Craig, and thanks for the clarity around, where this is positioned, because I think it feels like it's a refresh we have to do, but actually some of the content of this I think is really useful. So particularly, as you said, bringing in some of those real life examples of those shifts towards prevention, community and digital, I think really bring some of what we're doing to life. And going back to my previous comments around ensuring that we don't lose some of the good work that's happening at the moment, because we're in such financial pressures, I think this has a lot of capacity to really highlight some of that work, and whether that is when it goes to health and wellbeing boards, or whether there's other discussions that take place across the system to say we know we're stepping in the right direction with these three key areas. We also know that whatever plans we produce in the future, whether it be a joint forward plan or others, are going to ask us to emphasise that direction of travel. I think some fantastic ways in which we're doing that. How do we capitalise on that more? How do we share that learning? Because some of these are quite place specific kind of things that we're doing. And as I said before, make sure that actually there's no unintended consequences of some of the cuts, so we lose some of this good work that we're highlighting now.
Thank you. Thank you very much, Tracy. So I'm going to ask the board to approve the update of the joint forward plan, the addendum, and to agree an updated plan as we've discussed in due course when the NHS 10-year plan comes out. Thank you. So we now move to performance overview, and we're going to start with the reporting from commissions, the escalation committees, escalation and assurance reports, starting with Debbie for the last report from Primary Care Commissioning Committee.
Thanks, Chair. So there's two AAAs shared in the board pack from Primary Care Commissioning Committee from the January meeting and also the February meeting. There's no items for alert, but there are items obviously for advice and for assurance. I'm happy to take any questions. There's probably a couple that I'd just draw attention to. So from the January meeting, there was a review of the general practice quality contract and the in-year delivery, just so that we had an understanding of the patterns of delivery, to be able to support optimising that by the year end. And we agreed actions there to support that, to improve in certain areas, noting that there was variation in terms of the geography and also against those packages of care that were being delivered through the contract. So that's been taken up and moved forward. From the February meeting, the committee looked at the dental commissioning plan for 25-26 and reviewed the plan that had been produced internally by the team based on evidence. So that's been inbuilt and is being considered through the commissioning intentions work. So it's just ready to give assurance that we have had a finer grain look at that and made some recommendations for consideration. And then the final point around the primary care integrated performance report. So we received that at each meeting, and I've just drawn out for attention, and it triangulates with the later performance report where there was some areas of difference in delivery or under delivery against national targets, just so that the board are cited of it on it, and just made reference to the fact that there's continued work really to make sure that that report supported the committee or the board to be able to get an understanding of what's happening, why there's that variation, and what we could do about it really to improve the support and the delivery moving forward.
Thank you, Debbie. Any questions for Debbie? Jim?
It's a comment rather than a question. The primary care integrated performance report, the point you made about practices delivering in excess of 1 million appointments for the first time, it feels like we should be we should be recording the successes occasionally and celebrating the successes. You know, we have so much bad news.
Yeah.
There's some good news in this report, and it just feels like we should be noting.
Thank you.
So, you know, well done to everybody involved around what's going on in general practice around those figures.
No, thank you. Well made. Okay, I'm going to now ask Sheena to give us the escalation report from Quality Committee, please.
Yeah, thank you. So the AAA report is from our meeting on the 22nd of January. I'm just going to highlight to members of the board the items under the alert section, assuming people have read the other two areas on advising and assurance. So the first of those was a mechanical thrombectomy, and we've already reported to the board the challenge that we have around a gap in service in one of our trusts, which we're working with particularly specialised commissioning, because this is a service that is commissioned by the specialised commissioners. So we felt that we really needed further assurance about the improvement required in this area, and we have requested that, and so we will continue to keep a close eye on the how this moves forward, so that we can get that assurance around the mitigations and addressing the gaps that there are in that particular area. The second area I just wanted to bring to the board's attention was around the issue that actually we've already talked about quite a lot in the meeting, which was this issue about transition and transfer of care and communications. And when we consider things at the Quality Committee, we also try to think about using the knowledge and expertise of people around the table, how we can make suggestions about how we can move things forward. And we felt that in terms of where the focus of this needs to be is really in the work on integrated neighbourhood teams, and the opportunities there are and the improvement work that they do to actually think about improving that communication and those transfers of care. And so we asked that could this be picked up in the transformation work that's being undertaken across Lancashire and South Cumbria. And then the third area you'll note was around our work in one of our statutory areas of an ICB, which is around the court of protection, deprivation of liberty standards and safeguards. I just really wanted to note the mitigations we're putting in place there around some of the challenges we've got in that area. So I think that's what I wanted to report. Thank you.
Thank you. Thank you very much, Sheena. Any questions for Sheena? No. Okay. Roy, finance and performance. I know there isn't a sheet here because it met relatively recently.
Thank you, Chair. No, there isn't a report appended to the papers. That's because this meeting took place on the 12th of March and the papers for this board went out on the 12th of March, and so we weren't able to do that. So I'm happy to provide a verbal report this afternoon. We have a couple of alerts, some advisory issues and an assurance, and one assurance issue. So on the alerts, and you'll probably be aware, I think when we spoke about the finance in the past at this board, and I've made reference to, I think it's reflected in the minutes actually, that we agreed this afternoon that there's changes occur quite rapidly within the finance system, and you'll probably be here within our finance report later from Sam that some of those changes have happened since our finance performance meeting last week. So on the projected outturn for this year, we had a projected outturn at month's 10 after deficit funding was 166 million overspent by providers and a 20 million overspent by the ICB. And in respect of that ICB work, in respect of the ICB, sorry, work was continuing with a view to delivering a balanced year-end position. And as I say, Sam, I think will update us on that in the finance report later on. On the 25-26 efficiency savings, given national targets, I think convergency funding adjustments and the need to repay past deficits, and this is really important for us to understand, is that the Lancashire and South Cumbria NHS system needs to deliver a 3% efficiency saving next year just to stand still. So that's really important for us to hear, because I think just to stand still would deliver 3%. So obviously we've got to add more savings on top of that. I think it's going to be hard, but it's achievable, I believe, and we've been working on that this morning on another meeting. So if to address those underlying deficit is going to require even further efficiencies within the systems I've already alluded to. On our advise items, we have all age continuing care, which again we'll probably refer to later on in the agenda, and noting the significance of all age continuing care, which obviously includes continuing health care, to the ICB's net financial position and the need to oversee quality. It was agreed that consideration be given on how best to report into assurance committees and the board. So I think we agreed, Chair, at the meeting that discussions needed to take place outside the meetings with a view to report back to the next cycle of the meetings on how we achieve that. On capital planning, the committee highlighted the need to assess the implications of the deferral of the new hospitals programme on the use of discretionary capital allocations. Clearly, we've heard in the media about the new hospitals programme, how that has been delayed in some areas, and particularly within our own area. And we obviously agreed at the F&P meeting that further discussions need to be held at that meeting to refer to that particular issue, so we can keep bringing it back and keeping it to the forefront of our attention. Again, on the advise position on 18-week waiting times, the 2025-26 planning guidelines state that 65% of patients should wait no longer than 18 weeks for treatment by the 31st of the 3rd, 2026. The ICB's current performance on this new target is 60.5%, and so we'll require further progress on that in this forthcoming year. So we're asking board to note that position. On the single assurance issue that we want to bring back to the board that was discussed at the Finance and Performance Committee was the business case process. The committee, subject to minor changes, supported that proposed new business case process, and I'd just like to thank the author and Asim and whoever's been involved in that. The non-executive members went through, I think, 1 or 2 iterations of that paper before it came to the F&P committee, and we made some changes in there. And I particularly like to thank Jim for his involvement in that as well. But we're asking the board to endorse the adoption of the business case process. There were a few general housekeeping points to that particular paper. Therefore, it isn't here today, but we will bring it back. It will come back to the board for formal endorsement and approval at a later stage. Thank you, Chair.
Thank you, Roy. Any questions for Roy? No? Okay, thank you very much. So we will move on to item 12, which is maternity and neonatal services update. Over to you, Sarah.
Yeah, thank you, Chair. I think it's about 18 months since the board's had a report on maternity services, but I'm sure people will be aware that nationally there's been a lot of scrutiny on maternity services, and there's been a number of high profile cases of maternity units where care hasn't been safe, and public inquiries. So I think it's really important to give the board assurance of where we are with our maternity services. So all 4 of our acute trust providers in Lancashire provide maternity care, and what the paper does is bring out, there is a national, on the back of things like the original Kirkup review and then the Donna Ockenden review of another maternity unit, there is now a national delivery plan that all ICBs have to have oversight of through their LMNS, which is the local maternity and neonatal system. So that's how we assure ourselves of our maternity services, and I have oversight of the LMNS, and we do report into Quality Committee regularly of where we are. There are 4 key themes in that national plan that we monitor, and they are highlighted in the paper. So in the spirit of time, and that people will have read it, I won't go through them all. I'll just pull out a couple of key points. I wanted to really pull out the work that's done on listening more to women and families, and what the paper does is describe the pilot of the maternity and neonatal independent senior advocate programme, and David and I have a number of really constructive discussions around this, and different systems did this in different ways. So we were one of the first to go with that pilot, and we've got a midwife who leads that, but David's put some very constructive and helpful challenging around, can a midwife be truly independent as an advocate? And in the Cumbria and the North East, I think it's a different approach, isn't it, David? So I think what's really good, though, is there's going to be a national evaluation of that scheme, as the paper highlights, and we will keep an eye on that to see whether the model we've got is the right way forward, or a different model, or whether it'll even get funded, I guess, going forward in terms of that scheme. But you can see in the paper some of the outputs of that scheme and some of the women that we have managed to help. Then there's an outline on workforce, and all of our trust try and staff linked to birth rate plus, and this is a good example actually of some of the challenges when it comes to commissioned services, because birth rate plus is a national standard that has come out of safety and quality concerns. but some of our trusts might argue that's not ever been fully funded in the contract, but yet it's a standard and an expectation that we need to have. Now, you know, we're not going to compromise maternity care, and we don't compromise it, but it's another one of those where Chris's point really about how does the LMNS and the providers work together to make sure we're staffing to those levels, but we do that in a way that you know, is affordable and at long run. Then there's the thing around culture of safety, because I think in all the high profile cases where there's been challenges in maternity units, one of the themes, if you read any of those reviews, is around poor culture, and poor relationships between clinical teams is often a real theme, and the report does tease out in our trusts how that relationship between obstetricians, midwives, neonatal units is so important, and we review that. The report also pulls out our figures on stillbirth rate, and it's reassuring to hear it. These things fluctuate, that there's nothing flagging of an issue for us in Lancashire. We are below the national average for that, and similar neonatal early neonatal deaths, it does fluctuate that sometimes, as you would expect, but we are at about the national average for that, and every time there's anything like that we go in and review. And the last thing I'd say is the LMNS team have a really good relationship with all of our trusts. They do regular quality visits, which is where we get our assurance, not just on data, so we triangulate with that. And you can see that 2 of our units still remain on the MSSP programme. That's the national programme. It's a shame Aaron's gone. We are hopeful, all the indications are that Morecambe Bay will come off that programme at the beginning of May, but Blackpool Teaching Hospitals remain with that intensive support from the national team. So I'll stop there, and I'm happy to take any questions.
Thank you very much, Sarah. Questions? Okay, Tracy, and then David. Thank you, David.
Thank you. Thanks, Sarah. Really interesting to see how kind of this review split into those different sections. But one of the questions I have is about inequalities, and how maybe you talked about triangulation statistics and looking at different sections of the community. So there's nothing in this around how women of colour fare within maternity services, and of course we know from statistics that actually there's some startling statistics about you know, the disadvantage that women of colour experience in maternity services. It just seems like an omission to me that there isn't really anything in there that talks about that.
Yeah, so I think that's a really valid point. So apologies, because we do actually have one of our LMNS team is our inequalities lead, and does link really closely with our population health team. So that focus is definitely there. So I will make sure if we do a future report that we bring that out. But I'm sure Alex would be happy to meet with you all colleagues to talk through some of the specific work that they are doing on inequalities.
Thank you. Really important point, Tracy. David, and then Jim.
Thank you. So I just wanted to talk again about the maternity and neonatal senior advocacy post, as Sarah would expect me to do. So there's been some national coverage over the weekend about the service, and a real strong criticism about the lack of independence. It's called an independent senior advocate, and yet it's an employee of the ICB whose job it is to help women navigate and complain and scrutinise and challenge the services that they've received that are funded by the ICB. So it's likely that the review, in my view, will find that that role does need to be independent, like mental health advocacy is, Care Act advocacy is independent, and so on. So I just suppose I want to encourage you to rethink now. It's within your gift, I guess, to make a change to how that's done. It's really important, in my view, that we've got a level of independent scrutiny around this that is separate from the ICB.
Thank you, David. And
yeah, I mean, I acknowledge we've had many discussions, and I don't disagree with David's point, but I suppose we were now, because we've already committed, there's an individual in that role. So I think, you know, where we've got to is to let the pilot finish, look at the report from the pilot. We also need confirmation that scheme's going to be continued to be funded going forward, and then we will take stock. But you know, your points have always been very well received and made, you know, very valid. So we have taken those comments on board, keep it under review, but we are waiting for the outcome of the national review.
Okay, so it's a pilot that's under national
It's a pilot.
review.
It is a pilot. Yeah.
But yeah, you're right, David, to keep raising it. Jim, I think, was next, then Chris.
Thanks. It was very helpful to see this, but I'm not an expert in this area, and at the end of it I wasn't sure what to think, basically. So I I'm not necessarily picking up assurance on this because it doesn't say be assured. It says please note the contents of the report. So I'm not sure whether we're happy with the services and whether there's any specific items we should be concerned about. So it feels slightly incomplete report to me. So apologies, sir. And I know there's a lot of work gone into this and there's an awful lot of information in here, but I'm not incapable of making an assessment on this. I want someone to tell me whether we're doing what we should be doing, and this doesn't quite do that for me.
I think that possibly picks up a little bit on Tracy's question, actually, in terms of, I think where we get assurance. So there's quite a bit about the mechanisms in here, and that's really important. And it's really important that we have that and that assurance. But we probably also need to see some more about the outcomes and the benchmarking and how we compare in reports of this kind generally. But so I think it's a fair comment. I think it came from a particular question around the mortality figures that we wanted to see, and they are in there, to be fair. So I think it came from a particular perspective, but I think a learning for the board is that when we have a report like this, there's no point in just focusing on the thing. If we're looking at maternity, we should look at maternity in a slightly more holistic way. Sheena, are you coming in on this?
Only because clearly the main sort of more detailed work on assurance takes place in the quality committee. So I think perhaps we just need to reflect on that in terms of we do pull through things from the quality committee and the AAA on maternity. So I wouldn't want Jim to think that we're not looking at assurance through the quality committee. So, you know, it's really about just linking those two things together. And, you know, we do at times we do go into deeper dives on areas where we don't have the assurance that we need and continue that. So I think perhaps we need to contextualise it better. That might help Jim with his question.
I think that's absolutely right. Thank you, Sheena. Thank you very much. Chris.
Thank you, Chair. Thanks, Chair. It's an ask and an offer, I suppose, Sarah. And with the comes to your point, Chair, around the more holistic side to maternity and do we look at maternal mental health and how we bring in the perinatal services? And I just think in Lancashire and South Cumbria, we've got a gold accredited perinatal service for acute and inpatient and community. And I think maybe our teams could support Sarah's team in putting something in to get that wider rounder piece.
And again, we do pull that through at quality committee. I suppose, you know, next time I need to be clearer about what board want in the paper, because the paper could have been 3 times fuller. There is other work going on around this, so but we do definitely pull that through at quality committee around
No, thank you. And I think that's right. I think this was what this paper was being brought to. There's a difference of understanding. We just need to be very clear with the cover papers. Thank you. Any other thoughts? No, thank you. Thank you very much indeed, Sarah. So we now have winter response and urgent and emergency care, which is back to you, Craig.
Thank you, Chair. So, board will be very familiar now with my reporting on UEC. I'm hoping everyone's had an opportunity to read the report. So just some highlights. We cover all of the requirements, as you know. In relation to our national ambitions on performance, just to remind board members, A&E waiting times for 4 hours is at 78%, which is an increase from previous years, and category 2 response with an average time of 30 minutes. You'll see under section 3.2, we were ranked 14 out of 42 integrated care boards at a performance rate of 74.5. The data as of last week is we are at 76.4, so we're now 8th ranked out of 42, so an improved position. We've also engaged with NHS England and we have worked with one of our particular providers, UHMB, to talk about pushing the system further in March to try and improve our position. So I was here last year and said I was very hopeful we'll get to 76% then. I'm saying the same for the 78%, but it will be very, very close. So we are doing our absolute utmost with our providers where there is good performance to see whether we can just go that slightly bit further to reach the target. We've also got a system reset, which is a part of our interventional support offer from NHS England, and that is happening next week between myself and the Chief Operating Officer in NHS England North Region. In relation to CAP 2, overall, from April last year to late February this year, we were at a performance of 26 minutes 32 seconds. We slightly dipped in January, so that's but I'm hopeful again that we'll be able to report that we met that standard. And I've got some details in the report on other elements of the waiting times, etc., which are still a challenge due to our pressured UEC system. We have changed the focus of our UEC delivery boards. We are stress testing our improvement plans for next year, as they're also linked to our financial plan for delivery, but more importantly because we want to improve flow, and we also recognise that the management of our UEC pathways, not just through our front door A&E, it's right the way from primary care into community and out of the back door. I chair the Strategic System Oversight Board now, and we have given that a very specific focus in managing performance, as well as some of the implications for what it means in relation to improving the quality and patient experience with regards to our financial position. It talks about our capacity investment funding, which is in our baseline this year. We've committed that we wouldn't be spending any more than outturn last year, which I think was part of the principle. So we would want to review all of those schemes and ensure that we've got robust cases in place before we do any further investment funding going forward. And we're continuing with the 10 high impact interventions for UEC recovery. And finally, there is a huge amount of work ongoing regarding not meeting criteria to reside. This happens, as you know, we've reported previously in different parts of the system. There is a mixture in relation to that performance, and it varies from percentage terms. UHMB has been the most challenged system in relation to that no medical right to reside, and we've been working hard with Lancaster to look at adopting a similar model to Barrow. But that's not to say other areas don't have the challenges, but we're working closely with our local authority colleagues to address some of the issues regarding delays in people leaving hospital. I'll leave that there, Chair. Oh, sorry, the final bit is we would now step down these reports for board until the winter happens again, and I then be updated on a monthly basis.
Thank you. Thank you very much, Craig. Questions? So I've got Sakthi and then Jim.
Thank you, Chair. Thanks, Craig. I just wanted to remind the members of the board about the conversation we were having about flu vaccination a few months ago. Sadly, that doesn't make the cut for the 10 high impact interventions, which I'm a bit perplexed, but that's different parts of the national system probably doesn't align when it comes to winter planning. Could I also highlight that people, especially with respiratory illness, most of them who are turning up into the hospitals are also smoking tobacco, and those two interventions, if we can really ratchet up during summertime, and indeed when the flu season starts again, could go a long way in helping us achieve the outcomes that we're trying to achieve here. So I'm just wondering whether the Strategic System Oversight Board or the mechanisms we have and this board could actively seek assurance on how we are supporting people, especially staff with flu vaccination, as well as to support people with stop smoking support.
Thank you, Sakthi. Craig, two good questions.
Absolutely. I think this cuts across multiple parts of our governance, so I'm not just convinced it's for our Strategic Oversight Board. I think there's a role here for the Integrated Care Partnership as well, and I think we've got a role in working with our partners in local government through public health colleagues like Sakthi. I do think it's an important point though, and we have raised it in health and wellbeing conversations about vaccinations. And I think we do need to take a proactive approach, especially with the staff vaccinations in our acute providers and mental health providers, as I think that's a challenge. And I think as a part of our integrated commissioning contracted meetings now, that was going to feature in our monitoring in relation to where we are from a trajectory point of view.
Thank you. I've got you, Julie. Jim.
Thanks. This is such a complex and difficult and multifaceted task, and we've managed it again through Craig and his team here, and through all the providers and the local wider system. It just it's a really good outcome, I think, and the work that's going into this coming winter again is positive, and I think we need to build upon the successes of last year. So it's just really to record, I think, the fact that we got through the winter again, which is a great achievement. We did the previous year, but it's such hard work for so many people, and I suppose to express our collective thanks to everybody involved in this.
No, thank you, Jim. Well said. Julie.
Craig, it's a great piece of work. I just wanted to highlight primary care here though, because it's not visible, but we do exist. And like you're saying, great piece of work, and we did lots with the acute respiratory hubs, which was all performed in primary care. Bringing back to Sackley's point about smoking, if delivery is undertaken in pharmacy and in general practice, then you get a buy one, get one free. Because not only are you managing that acute presentation, that you're dealing with the preventative areas. Also, just to add to that slightly off topic, is that Morecambe Bay is an area where you have massive presentations at A&E and frontal use, but we're about to see some changes potentially to the contract which remove the services that are available for minor injuries that are provided by general practice. So it's just to highlight that whether or not that has been looked at in terms of the additional risk that may place on you next winter.
Thank you, Julie.
So on the latter point, there is an assessment of all of the potential changes that the providers will be doing to look at impact, and some of these potentially may look at a deteriorating performance going forward. So I think it's just something we need to be cognizant of. The primary care elements were reported separately, but I do think there's an absolute valid point that Julie raises for next year's report, and I think it needs to be an integrated report. So I think we'll be working with I know we'll be working with our primary care colleagues on what intelligent information we have, how we can crystallise it, and how it can add value to this paper.
Thank you. Good. Okay, so I'm going to move on to the integrated performance report, which remains with you, Craig, in Asim's absence.
A very quick brief, as I wasn't expecting to take this paper, but the performance report is here. It is again a standard report that all members of the board should be familiar with. I think just some highlights. We have seen patients waiting increase marginally in month at the end of December, so a slight increase in our waiting lists. The number of patients waiting over 78 weeks reduced, and we are working on the basis of having 0 78-week waiters by year end. There's also an ambition for that in relation to 65-week waiters, but we are not at 0 yet. We've got a small number that are over. 60% of these are in relation to a particular speciality, gynecology, and the majority of them are at Blackpool. So we know that, and that we're doing some intervention there. So we do have details in the report. So end of 2025 forecast, there's a proposed 185 65-week waits at the minute, and we're working hard to reduce that number. I'll obviously report to board if we do breach the 65-week waits and the reasons for that, and any remedial action that we need to take. I've updated already on UEC, which is included in the report. And I suppose just the final bit is cancer. So we met the 28-day faster diagnosis standard by all providers, and we're 6th out of 28 alliances nationally. The 31-day has also seen an improvement. And we've now seen both Blackpool and Morecambe achieve their target. So again, we're now 77th out of 20 for the alliances, but we do still have challenges with our 62-day standard, and again some real focused work that we are needing to work on, that we've focused the Cancer Commissioners to look at going forward. There are a number of other elements that are included in the report, and rather than maybe me just pick them out randomly, I'm happy to answer any questions, whether it be diagnostics, and obviously if there's other elements that relate to other exec members, I'm sure they can field them as well. Thank you, Chair.
Thank you, Craig. Julie.
Thank you, Craig. It was a comment around diagnostics, actually, that I feel the paper is maybe not showing the goodness that is also going on, because there's a real increased access for patients right now through community diagnostic hubs, which brings investigations much closer to home. It's really saving on transport, and actually those hubs are offering innovative tests that are really up to date and haven't been available before. And we've not seen that access until this year. So actually there's some really good stuff that maybe the data's not giving us that. Thank you.
Thank you. Chris.
Thank you, Chair. It's more a comment, Craig, and I'll pick it up with Sim, but it's in section 8 when we talk about the learning disability and the annual health checks, and at 46%, and we've achieved that milestone. And whilst that is what was agreed, and that's really still not great, is it, for a system? And when we look at the 25-26 national planning guidance, annual health checks for learning disability have been removed. And we know the huge impact on health inequalities, life expectancy, but especially from our BAME population with a learning disability and the significantly reduced life expectancy. I just think there's something for the board to think about. Do we still keep that going into 25-26? But we can pick that conversation. It was just really to know.
Thank you. Thank you for raising it, Chris. I've got Roy first, David, and then you.
Thank you, Chair. Just to agree with Julie's comments on the diagnostic hubs and the work that's going on in those. I was surprised actually when I read this that that had deteriorated that target, given the amount of work I say that does go on within those community hubs, including in Blackpool. They have MRI scanners that people can access. So it's a really good service that's going on there, and we've talked about improving that service within the community several times here at the board. And I think that is happening now. And again, as Julie said earlier, that is absolutely supported by our patients in terms of they can directly access some of those community hubs with just a card from their GPs. So they get a card GP, they can go along and they can access the hub and get an X-ray or even get an MRI scan within a very short period of time. So I think they're a really good benefit to the community and to us as an ICB.
Thank you, Roy. David.
Thank you. It's just a comment really, not a question. But reading this report, I was left feeling sad that we're not doing better for the citizens that we're here to serve. And I'm kind of when I read this report each time, I mean, this certainly looked like things have got worse in many areas. I'm left wondering what we do with it, and I wonder whether or not a conversation with you, Emma, might be useful. But I end up sitting thinking I'm not sure that we drill into this enough, that we get enough assurance around some of the things that are this worsening picture. That, with the backdrop of lots of changes to services, leaves me feeling a level of concern that I think I'd like to discuss further. Really.
Yeah, I'm
not sure what to do with that, but I just thought I'd make the point.
No, I mean I'm more than happy to meet with you, David. I think there's also something about the role of the ICB and how much of this is second guessing what providers do. So we have a lot of in here that is also considered by all the provider boards as well. So we're duplicating. What we're not then doing is some of the questions that you've been asking around, are we reducing inequalities? So the report is, and ASIM is more than conscious of that. So there's work underway in Q1 to look at this report and to look at saying, what should we be looking at as an ICB that we should be effecting change over, and so that we can so that some of the questions you ask, we can say yes, this is what we are doing about it. Because I think in some cases here it's a bit of a mixed bag. So, but I'm more than as always I'm more than happy to meet with you as well. But I think that work is planned for Q1, isn't it? Great, thank you. Okay, we're now going to move to the finance report. Sam.
Thank you, Chair. And I'm going to start with the question that was asked really at the start of the meeting. So we had a question, and thank you for questions. It's always good to receive questions from the public. The question was why Blackpool Vic has absorbed savings of up to 50 million forced by the ICB when the overspend was by the ICB. So this is a really complex area, and I think I just probably wanted to start just to explain how some of the funding works here, because we have an allocation that's set nationally for every ICB in the country, and that allocation is based on the demographics and a lot of profile of our population, and it's deemed to be the right level of allocation that we actually should receive. For our ICB, that's just over £5 billion. The ICB running costs and programme costs for us to run this organisation is only 1% of that whole budget. It's 30 million running costs and about a similar amount in programme costs. The rest of it goes right out to the system to run hospitals, to give to providers, to primary care and prescribing and everything else. So it's not that the ICB has an overspend. We have an allocation of money that we have to then provide out to our providers. So the issue we've got in the system more generally is that just over £5 billion is being overspent in the system, and this isn't a new thing. If we go back before COVID, in 1920, the system overspent by almost £200 million just before we hit COVID. The ICB wasn't here then, and we had an overspend of just almost 200 million. And what happened during COVID, if you remember, it feels like a long time ago now, but it was really important that this wasn't impacted by money, that we had to look after everybody and make sure that safety was paramount. So we were given top-up funding for that £200 million to make sure the whole system balanced and that money wasn't a problem. And on top of that, we were given another 200 million to put services in for COVID. And that's what a lot of our providers did. They put a lot of money into those services. Then when COVID ended, that money has been withdrawn. So we've had 200 million taken out for COVID. And on top of that, because we've got this other 200 million that's built into our allocation, we are deemed to have too much money for our population and we are over allocated. So slowly each year we're losing about £30 million a year through something called convergence. So over the last 3 years, we've lost about 100 million through convergence and we've lost the COVID money, but yet the services that we were providing are still there. So this is the issue with all of our providers and the system, is that we're spending too much money on services that we set up that haven't then been stood down. And so what we're trying to do is address that as a system. So I'm really happy to give more information and maybe more of a briefing on this because it is a very complex area. But I suppose the key thing, as the chair pointed out at the beginning, is while we're spending more money than we're being allocated, somebody else is losing out and we've got to stay within that allocation. So the work that we're trying to do is to look at what we need to do to change that. And that's why transformation is so important, because if you look at what we are spending that money on, post-COVID or during COVID, we set up an awful lot of things, a lot of services and additional staffing through agency and bank that are running high-cost elements of our urgent care pathway. And that includes things like corridor care and its escalation beds. It includes things like the out-of-area placements that we have in mental health. None of these things we want to do, and all of these things cost too much money. It's so much better if we can prevent that by trying to look at this left shift, out of hospital, how do we do things more in primary care in the community that will actually cost potentially less, but actually as well be better for our population. And that takes time. So that's what we're trying to do. So I think hopefully that answers some of the question. I know it's a complex area, but it does lead on to my finance report really. So I'll go into that now if that's okay. And I am going to assume that people have read the report, but I suppose that we're at month 10 now in this report, but actually we're on the 19th of March and in less than 2 weeks' time we're going to be at the end of the financial year. So we started this time last year with a really ambitious plan, and that plan was to address some of those things I've just talked about, to try and address the high costs in our urgent care pathway and the things that aren't particularly great for patients, by putting a lot of work around that pathway. And it fits very much to what we've heard today in the 2030 vision and in the joint forward plan around managing long-term conditions, improving end-of-life frailty, intermediate care. These are all the component parts. But to do all this in 1 year was really, really challenging, and we've really struggled to do that. It's still the long-term transformation, it's still the right thing to do, but we haven't been able to do it quick enough and fast enough. And that's why we've sort of fallen off as we've gone through the year financially. what we have been given, and coming back to Jim's point that he raised before, we would have been heading into this year with, it's around, and it's in my report, around a £350 million deficit, but we have been given deficit funding of £175 million to support that, so that won't be our reported position. And in fact, as somebody else has said in this meeting, things are changing so quickly, we've actually been allocated another 50 million of support funding in the last few weeks. And what that's going to mean is the reported position in the ICB will be a break-even position, and the reported position across all of our providers will be about 130 million off plan, and that will be where we'll end the end of the year. But that's with all that support funding in it. So I just need to make the distinction that the actual deficit, underlying deficit, as Jim called it, is around 350 million this year, but we are going to end up in a better position because of the support funding that we've been given and supported by the national team. So what I would like to say really is, despite all of that and despite us not meeting the end of year position, and it is, we've got to really ramp up our plans to try and address this as we're going into next year. We cannot continue to be in this position. We have made at the moment up to month 10 almost 300 million pounds worth of savings, and yet we find ourselves in this position. We made over 200 million savings in previous years, but we're not going fast enough. So this is going to take something more radical than we've been doing. So we've been concentrating very much on what's the right thing to do, but we are going to have to make some difficult decisions to do it, and that's where it comes into the difficult decisions. But we're very, very, very keen that we make sure they're in line with our transformation plans. So this is a difficult balance, but with the intervention we've had, it's actually shining a light on some of the right areas, and it's been really helpful. So what we've been focusing on in the last couple of months is how do we get our run rate, our expenditure run rate down as we're entering into next year to give us a chance of meeting the plan next year. And that's been a really big focus, and thank you to all our provider colleagues and people in the ICB who are working extremely hard to do that, so that we don't have as many big things to do into the next year. And we will be setting some big plans next year, but they have to be really, really robust, and we have to make sure we've got the teams and the things in place that are going to deliver these. So going into next year, lots of lessons from this year is, we know it was all the right thing to do. The plan wasn't wrong, but how do we focus on delivery? And that's going to be a big focus. So I won't go any further into that, other than to say that I think, you know, the commission intentions that we've heard from Craig today are really, really important part of this, because they'll help us to deliver that plan. And it's got to be in we talk about commissioning, but actually this isn't us and them. It isn't us and Blackpool Victoria and us and the Mental Health Trust. It's us working collaboratively around that vision and around those commission intentions to deliver this safely as we can. We're expecting some ongoing support from the national team again, who've been very kind in supporting us to give us a chance to do this over a couple of years, and we've got to do our bit now and deliver that. So that's probably all I want to say, but I'm happy to take any questions on the detailed report, and we will bring more information back on next year's plan when we finalise that.
Thank you very much indeed, Sam. Are there any questions for Sam? It is quite a complex picture, but I think you've articulated it very clearly there. Yes, Denise.
Thank you for that, Sam. It's very helpful to understand the picture. I think it's not really a question, it's more a comment. I think I said it last time. There are going to be some really difficult decisions, and obviously the latest messaging from National will add to that, but we know this is going to impact. I think it's, you know, we're here as partners to help with the messaging and the public understanding of why some of these decisions have to be made and the consequences of them, and trying to help with that. I think equally we need to look at this as a system and avoid just cost shunting, which can happen, and unintended consequences, and really focus on that delivery in place, but working with our partners and not just local authorities, including the VCFSE, in that, to make sure that even though we are having to make those difficult decisions, we are putting our residents first and trying to understand the impact of them. And I think we can all help with that collective messaging and understanding.
Thank you, Denise. I think that's really, really important. And it's another, you know, I should have mentioned our local authority colleagues as much as our providers. This is about collaborative working, because at the end of the day, you know, it's our people, it's the patients, and it's our population at the end of this. And actually, what's really hard for us and all public services at the moment, we're under so much pressure to try and deliver within the resources we've got, and we will do our best to do that, but we could do even better if we come together. Yet the pressures placed on us at the moment could very easily get into cost shunting, to get into, and we've talked about this before, we've got to rise above that for our population, and we've got to work together, and I think that's what we are trying to do, and I really appreciate the support that you give to us and others across the system, because it is the right answer. Voluntary sector as well.
Yeah, thank you. Thank you very much indeed, Denise. It's much appreciated. Tracy.
Thank you. Yeah, I think while we're talking about finances, I also want to talk a little bit about culture and about communication as well. And we've talked about communication being important when we're talking about patient care, but also across our workforce. So I think there's a couple of things for me where maybe what we've had in the past hasn't always been very helpful in terms of the culture and communication across our providers. So I'm thinking about people understanding where they can make really clear cost-cutting decisions, and I think sometimes that information isn't always at the fingertips of people who work across our system, and I think we've got to get better at some of that so that everybody feels that they can have an input into this and make a difference. And I think also around the kind of culture as well is you know, you talked about deficit support. It feels like being bailed out of situations, and I know there's quite a lot of services across the system that have a legacy of not having any funding attached to them, and I think that's again somewhere where difficult decisions are needed. But also, do we have a culture of people feeling like, oh, this is just business as usual and we don't actually have to make any changes here, when actually the message really does need to be, this is not business as usual anymore. This is, you know, kind of crunch time, and we really do need to be honest, I think, with people across our workforce and of course our patients as well. But I think there's a lot our workforce want to do and can do to make some of these changes, but do we always provide them with the right information to enable that?
Yeah, I totally agree. And I think this is one of those, it's almost been a bit of a wicked issue, hasn't it, about how do we do this really, really well. We're doing lots of great initiatives on listening and engaging and communication and citizens panel and lots of things that we're trying to do. But actually, if we could crack that really well, then we're going to get a much better answer to what we're going to do. It's very, very easy. I mean, we could all balance the books tomorrow. I could do that tomorrow, but it'll come as a massive consequence, and we'll end up not having any performance and no, you know, impact on quality to extent that's not acceptable. So we can't do that, but we can do something better than we're doing by engaging and listening to people. And I really, really want to do that. And I know we've had lots of conversations, and I think we are doing it better than we did, but we're not doing it enough yet. And I think I would really like to hear from you ideas about how we do that better, because I think it is part of the solution.
Thank you, Tracy. Kevin.
Just reflecting on the wider financial picture, I mean, you probably heard the expression, wouldn't it be great to have high-level Swedish services funded by low-level American taxes? It would be great, but it's not the real world. The King's Fund showed that, I think, since the creation of the NHS up to about 2022, on average, there was a 3.6% real term increase in health spending, which is very significant over that period. Since 2022, which happened to be when the ICB came into being, we've had flat cash, and we've had, because we've been in NHS terms overfunded, we've had some withdrawals of funding, and partly that's a COVID issue as well. So that's why we have to, yet at the same time, there are lots of opportunities. There are lots of opportunities to do things faster, better, smarter. So that's why we've got to make difficult decisions, isn't it? And that's why we've got to actually do that in a considered way, with the patient at the centre here, and really do that recovery and transformation that we mentioned earlier. But we will have problems in terms of sequencing with funding falling out. So it's going to be really challenging, but I think we are doing the right thing. The reality is, to go back to the question right at the beginning, is the bulk of the overspend is in the acute sector, and that's not saying they're not doing a good job. They're actually perform above the national average in most areas. But that's where the bulk of the overspend is, and it's in 3 trusts in particular, which have gone into not 4. There are some pressures in the ICB itself, particularly around continuing healthcare as well. But the bulk of it is in the acute sector, and that's why we need to progress the reforms we're pursuing around admission avoidance to keep people at home, around end of life to make sure that people don't go into hospital as much as they do now for that, etc., etc. So all of that is really, really important to keep up, so that we pursue the transformation agenda, as well as have to balance the books for the ICB and the wider system.
Thanks, Kevin. I'm not seeing any more hands, so I'm going to move on. There will clearly be more updates on this on a regular basis. Okay, so we're now going to move into governance and assurance, and the first of those items is the Special Educational Needs and Disabilities Position Statement. Sarah.
Yeah, thanks, Chair. It's a long paper with a big action plan, so I'll try and pull out the key points and then take questions. What the paper is trying to do is set the national context, and you can see the exponential growth we've had in Lancashire and South Cumbria, and that's played out nationally. And I am aware that there is a review going on at the Department for Education at the moment around this whole system for SEND nationally, because it's challenged everywhere because of the growth in demand and the growth in need. But in terms of, and I just wanted to remind the board really, the paper talks about the health and the bill when it went through, and the need to have an exec lead for SEND, but also the SEND Code of Practice that goes back to 2015. So that is the legal framework, and that really outlines our role. So I would say as an ICB, we've got 3 key roles in this agenda. We are the statutory partner along with our local authorities. So for us as an ICB, we've got 4 SEND partnerships that we cover, that we're part of. So we've got Blackpool, and Vicky may want to comment. We've got Blackburn with Darwin, and Denise is here, Lancashire County Council, and then Westmoreland with Furness. In the last 12 months, and in a very short period of time, we had 3 statutory inspections. We had Blackpool, I can't remember exactly when it was, about 3 months ago, I think, Vicky. Then we quite shortly afterwards had a JTI, which was a safeguarding inspection. Then that was followed by a SEND inspection in Lancashire in December, and we've recently had a Westmoreland with Furness inspection that hasn't yet been published. And I think Denise and I would probably both expect the Blackburn with Darwin SEND inspection to happen in this next year. So that is a lot of inspection activity, and even though the ICB is we get inspected, it's CQC ring us as well as Ofsted running the local authority. But for our providers on the patch, they are very much part of those inspections as well, because it's their services that have been provided. So that's been a lot of inspection activity on top of everything else we're hearing about today, winter pressures, operational pressures, financial challenges. So I just really wanted to pay tribute to all the frontline teams across health and social care, but health in particular from our perspective, who have really stepped up during those inspections. And despite the challenges which are pulled out of this paper, in all of the inspections to date, the inspectors have pulled out the dedication and commitment of frontline teams and clinicians in what is a very difficult agenda because of the level of demand. I think it's important to acknowledge that, and it's important for me to thank those teams because they've had to respond very quickly to asks from inspectors. What the paper then pulls out is the challenges, and then our other role is on education, health and care plans. So when a child has been, some children end up on an education, health and care plan, there is then a need for education, social care and health to jointly put those plans forward. But it's our job in the ICB, our teams, our very small team, to do the quality assurance checks on those education, health and care plans, and they're meant to be reviewed regularly. And there's a real backlog, particularly in Lancashire, which is what was pulled out in the inspection on those EHCPs. And if you're a family who needs a review to make sure the right needs are being put in place for your child, and that review is 1, 2, 3, 4, 5 years out of date, that is a really poor experience for you, for that child and that family. And then our other role as an ICB is to commission the pathways, the care across the neurodevelopment pathway, to make sure that that's right. And what the paper pulls out, and what the inspection and the pilot we've done of the assurance framework pulls out, is as the ICB stepped up, it's a very, because this ECG is operated as separate entities, it was very varied and very different how these pathways have been commissioned. So at the moment, depending on where you live in Lancashire and how old you are, that will determine whether if say at school you were starting to demonstrate need or behaviours and somebody thought that you might have autism and wanted to refer you into that pathway, depending on your age would determine whether you get referred into a community paediatrician for that assessment or whether you would go through to LSCFT for CAMS to do that assessment, and then it also then depends on your age. So it's a really varied, fractured experience, and like Sam, I want to acknowledge the question. It's quite a heart-rendering question that came in from the member of the public. Do I have to get my child sectioned to get any type of conversation or input from a psychologist? And how you have failed my family time and again, and round in circles we go in the NHS. I think I'd like to say to the member of the public, and we will respond formally, that I hope the improvement action plan that's in the thing, and I'll come back to that in a minute, and our commission intentions do highlight a need to do a whole neurodevelopment pathway review and recommission that whole pathway end to end, but that is going to take us a couple of years to do that work properly, and that is in our future commissioning intentions. I'd like to think when we do that and we do that well, that we will answer that, we will address that experience. I think some of the action we need to take immediately will start to mitigate some of the long waits and the experience while people are waiting. But I'd like to apologise to that member of the public because it's heart-rending to hear that. But that is the lived experience as has been found in the inspections. That is, unfortunately, the lived experience of too many families in Lancashire and South Cumbria at the moment. And even in the recent Westmoreland with Furness inspection, the CQC inspector gave us some examples of really poor experience for some families linked to long wait. So I think it's important that we acknowledge that and that needs to be addressed. The Lancashire inspection, the new inspection framework, there are possibly 3 outcomes. The worst outcome is if they find there to be systemic failings. And the Lancashire inspection, which I apologise it wasn't in the packet, is on our website. They did find that that the system had systemically failed children and young people we've sent. Now there was positives. There was also some positives in that report always, and I think again it's important for the frontline teams and the pockets of good work that have been done. That if you read that inspection report, there were some good examples in that report, but overall, and it was really linked to the EHCP situation and the backlog and the long waits on the neurodevelopment pathway and the fact that there's very little support, which is what I think the member of the public is pulling out while people are waiting. So to respond to that, because it was the worst inspection outcome, that now will be followed by an informal improvement notice by the Department for Education. And we met with them on Monday ourselves and Lancashire County Council representatives and others. They were really clear because of the way the framework's set up, and it's led by the Department for Education and the inspections led by Ofsted. That improvement notice goes to the council, but they were very, very clear on Monday that it's a joint responsibility for us to address the challenges that have come out of that report. And I think NH Single will write to Kevin as well, because I think that's just right and proper, because it is a joint responsibility. And actually, of the 3 priority actions that are pulled out in it, it's very clear that the weights in the neurodevelopment pathway, which is our commission service, are a big part of the problem. The priority action plan that you've got in the pack is a partnership plan. So these things that they're saying in there we will do aren't just for us to do as an ICB, it is a partnership plan. That is a draft. We've got until Tuesday next week to get the final version submitted to the DFE. It's come here today, it's going to the Lancashire County Council Cabinet meeting tomorrow, and we want it to be open and transparent, which is why even though it's draft, and it says confidential, it's gone in the public domain, both on our website and the County Council. But the DFE did give us some specific feedback, and partners, NH Single were there as well on Monday. So that won't be the final plan. The essence of the content won't change, but they've asked for more clarity on impact and outcomes. So the final plan will go in on Tuesday, but I do suggest, Chair, that it then needs to come back here for the board to formally receive it, because I couldn't get the changes that were asked for on Monday. This had already gone out in the pack. So really what we're asking today is that the board notes all the challenges locally and nationally on this agenda, but also notes our requirement as an ICB and the fact that because of the level of demand, we're not meeting all the requirements on the SEND Code of Practice at the moment. We are mitigating them as best as we can. It wanted you to note the finding, particularly from the Lancashire inspection, because that was systemic failings, and there is an expectation now as an ICB that we will support that improvement board, and the priority action plan is ours to own as well. We'd like to ask for you to approve, for me, to endorse the final plan that goes in on Tuesday, because there's not another board meeting before Tuesday, but I would suggest that then formally comes back to board for receiving at some point. And obviously our commission intentions have flagged the work, and the team have already started to do work on a neurodevelopment pathway. There is a programme board, we've been signposted to areas of good practice, but we know to recommission an end-to-end pathway across the whole of Lancashire and South Cumbria is going to take us a little while, particularly given the context, the financial challenge, but there will be some immediate actions we need to take in the next year, and it's for us to note that, but to for execs to go away and think about how we can look at reallocating some of our resource, because obviously we understand the financial challenge and context at the moment.
Thank you, Sarah. Jim, then Vicky.
Yeah, thanks for the paper. It's a very important and a very worrying document reading this. So thanks for bringing this to our attention. Obviously, it's difficult to comprehend the growth in demand for the service, and I know that there's conversations going on around the growth in the number of people who are claiming sickness benefits and the like, and it feels like it's all connected somehow. And there's a national issue about trying to understand what's going on here. But regardless, there are clear gaps in kind of the way in which we're providing services, and to say we're only 24% compliant with our statutory requirements is an extremely worrying position to be in. I was pleased to hear you say that you will be coming back to us for approval. This has got to somehow fit in with our commissioning intentions, which Craig is doing, and the reality of the financial situation we're facing. We talked about the need to take difficult decisions. There may be somewhere down the line difficult decisions to take on this one, so we can't do everything, I guess. So it'd be helpful for it to come back to us. But it feels like it's a really good piece of work, and it's good to hear that it's been done jointly with local authorities as well. So yeah, I suppose thank you for producing it. I look forward to seeing the final document that comes back to the next meeting.
Thank you, Jim. Vicky.
Thank you, Chair. Yes, it's, I guess, a comment and just to follow on from Sarah's report and a plea also, really, as a Director of Children's Services. And as Sarah touched on, undertaken was part of that SEND inspection for Blackpool in May of last year. So as Sarah says, it's a really, really challenging landscape. We know that. The Department for Education is focusing heavily on it, and particularly around the drive for inclusion in schools, etc. We know all of that. What I would really say as well is that, particularly around that recommendation 5 in Sarah's report, which again is around that need to allocate resources, you know, it's a plea from me. You know, these are children that are some of the most vulnerable in our society, and if we don't get it right here, you know, they then become adults. You know, they're so vulnerable. So I know we're in a very challenging situation at the moment, but I guess it's a plea from me to really try and prioritise wherever we can. Thank you, Chair.
That's a very, it demonstrates how impactful this is and how devastating it is on people's lives, doesn't it? Yeah, thank you. Thank you for your comments, Vicky. I'm going to come now to Chris.
Thank you, Chair. And I think Sarah's been excellent in this space, and I can, I'm only one provider of neurodevelopment pathways. Sarah's mentioned some children would be referred into community paediatrics within acute providers, and it's great to see that it's referenced in the Commission's intentions. I suppose my ask and what we need to think of as a board is the pace behind this, because there are children that were waiting in my services for over 5 years for autism assessment, and the impact on educational attainment and then employability is just massive, and we've seen some of the impact there, haven't we? That said, the ICB has given £3 million over the last 2 years to LSEFT to subcontract out to the BCFSE market for autism assessment. There are providers that can do this at cheaper rates, I think, than the NHS. We need to look at that, but it comes back to Jim's point, demand is just outstripping capacity, and without that full commission pathway, we're just going to continue to go around in this. So it's a high risk on the risk register for this exact reason, isn't it? It's not an easy, if it was an easy thing to solve, it would have been done. Nationally, I can't understand how there's not a national outcry more on this, because this is happening not just in our system, it's a national position. But yeah, I'm really pleased to see the commissioning intentions that help address some of the appalling things we've seen in the failings in the report.
Thank you, Chris. And I think I've got Debbie.
Thanks, Emma. So my comment really is firstly to thank Sarah, who's not here now, for the paper ready in the report, and yeah, she's just caring for someone. No, I just mean in terms of addressing the comments, Sheena, it's not a criticism at all, just so that we can share it with her. So it's just to thank her for the paper and for the report, and also to note the importance of this being embedded within the commissioning intentions, because that's the mechanism by which we can decide collectively what we need to do to underpin delivery and address the actions. I suppose the thing for me, and I made this point the last time we talked about Sun, is that there's some really practical things that we can do that don't require the redesign of a neurodevelopmental pathway. So as a mum of someone whose child's SEND, and also my other day job's working in a college, and so I can see firsthand the benefit of the educational setting. There's so much that either health providers can do or education institutions can do that doesn't require an EHCP. So I'm not denigrating the value of them, because they're so important from a parent's perspective and from a young person's perspective, but there's actually lots we can be doing in the meantime that doesn't require funding, but it requires an empowered view from the centre to enable schools to be able to do things differently, or providers to be able to deliver services differently. So support all of this, but just ask that we also think a bit round the edges about the other transformational stuff that we can do that's actually really simple and doesn't cost much, but does make a huge difference.
Thank you. Sakthi.
Thank you, Chair. Just to support what Debbie's saying there, in my experience, and it is a challenging area of work, but we are seeing some really good practice examples that are being scaled up and spread. So, for example, in Hyndburn, we just extending and giving life to what Debbie was just saying there, we moved some of the clinical activity to an early years setting and made it an open access to parents, and not having to wait on a long line. By the time the child gets seen, it's a year of their life, which is really significant, and that is starting to show positive outcomes. So patients are either satisfied or reassured, and if we detect early issues in language development, that can contribute to less number of children ending up on EHCP plans as well. So it's good for the child and its development. So I just want to put a little bit more positivity into this. It can be quite depressing, and it is the outcome of the result, but there are some glimmers of hope that are starting to appear in our system, and we need to get behind it and really put some more pace in spreading that so everybody can benefit, and not just in Hyndburn.
Thank you. So I think there are three things coming out of this. The first is, the first is an acknowledgement of the inadequacy of what we are currently providing. I think the second is an acceptance and a desire to look at the recommissioning through the commissioning intentions, accepting that that is a long-term thing, but that is how we will get to the proper answer. But in the meantime, I'm sensing that there are some things that we can do that will not necessarily cost but that we can make the best use of what we currently have. And I'd like to take an immediate action. So that's not asked for in this paper, but something that says, what can we do to help people now that don't require us to spend an enormous amount of money? Because actually, if we're going to spend an enormous amount of money, it takes a long time for that to impact anyway. What can we do to help the situation now? And I'd like that to come back to board, possibly via quality committee. But I think that's quite an important thing. I think the final recommendation is that this action plan will cost, and I need the execs to go away and find out how that is going to be funded. Because if we can't approve an action plan unless we can fund it. But we are clearly keen to pursue this action plan, so that answer needs to come at pace. Oh, is the board happy with that? Yeah. Thank you. Okay, we're going to come to I think the last item on the agenda, and that, nope, it's not quite. We have the annual report and emergency preparedness, resilience and response core standards. Back to you, Craig.
Thank you, Chair. So this is our annual report that we're required to do each year. We've also included our core standards as we have a positive updated position on our core standards. I take the report as read just to remind people that this is a part of both the Civil Contingencies Act and the NHS Act and the duties on the NHS in relation to emergency preparedness, resilience and response. I am the designated accountable emergency officer as well on behalf of the organisation. So it's my responsibility in relation to oversight of all of the standards and the assurance required. There's a lot of detail in the report because obviously it is an annual report, which I'm not proposing to go through, but just some of the highlights. So I'm just going to come to the ICB first of all. The ICB last year, when it did its self-assessment, which was then moderated by NHS England, so this is the 23-24 assessment, we were declared as non-compliant with 11% of the core standards being met. This year we are partially compliant with 77% of those core standards being met, so a significant improvement in the 12-month period, and there's been a lot of hard work and energy from the team, which is a very small team in the organisation, looking at a whole range of plans that we needed to put in place, our comprehensive response to our training and tactical arrangements, looking at how we manage our strategic on call, etc. So there's a lot behind this that in relation to managing incidents on behalf of both the system and the ICB. Just now moving to the system, last year the system was overall non-compliant, so not one of our providers was compliant. This year I'm pleased to say that the system has 3 of our providers as substantially compliant, and now the remaining 4 are partially compliant, including ourselves. So that puts us in a much better position for 24-25. Clearly we want to move to full compliance of 100% across all of the organisations, so that is the action plan for this year. But I think it's just to know all the work in which the providers and the ICB have done. We monitor this through our EPRR coordination group, and also I chair our local health resilient partnership forum, and we have a particular risk register, and just to alert that there are a number of risks, mainly in relation to how we look at business impact and continuity plans, and there's a particular issue about data and digital response, which we've just seen recently in the media with some of our challenges that we've had. The others, as you can imagine, like South Cumbria, adverse weather, flooding, and then we've got waste, fire, which we have a particular issue with in South Cumbria, and pandemic planning. I think overall we will continue to work with our providers in the improvement plans, and we will continue with our training and exercise programme, and I would want to be bringing a significantly further improved position next year, and we will be monitoring this, and I'll be updating the executive as appropriate. So I'm happy to take any further comments or questions on the annual report or the core standards.
Thank you. Thank you very much, Craig. Any questions for Craig? Jim?
It's just a quick observation really, and I made the same comment last year. We try and triangulate this to make sure we've got some degree of assurance, and I think the fact that you can quote all the incidents that they've already been involved with that were handled successfully, and I know every incident is different, and you can't necessarily say because you dealt with it correctly on that occasion, being right the next time, but we have got quite a lot of experience of dealing with incidents, so it feels like whatever we are doing is pretty effective. So it's good to see the situation's improving against all these kind of external assessments or whatever, but when something's happened, we seem to have managed it appropriately. So I think that's, from my perspective, that feels quite assuring.
That is the name of the game, isn't it? No, thank you, Jim. Any other thoughts or comments? No, it is assuring, and it's good to see the significant improvement across and reassuring, given the perilous times we live in. So thank you, Craig. Okay, we're now coming to the governance and committee review, and I just would like to thank Deborah for an enormous amount of work that she has put into this. I came up with the bright idea and some thoughts, and Deb has worked it all the way through to the paper you see today. So, Deborah.
Thank you, Chair. I'll take the report as read. I think it's just important to acknowledge that since this work's been concluded, we've obviously had the national messages, so there might need to be further considerations once the RCB is clearer on its role and functions going forward. Section 2 of the report summarises the scope and the approach that was taken, and that was very much building up from the functions of an RCB and grouping those into 4 core areas, and then using that to think about how would we get assurance through those, either through the executives and exec functions or through our assuring committees or directly to the board. So that's described in section 2. Section 3 summarises the outcomes of the review, which are proposing a finance and contracting committee that would focus on scrutiny of the ICB and systems financial performance and performance of commissioned services against contracted activity. A quality and outcomes committee that would focus on the ICB ensuring continuous improvement in quality across the system and the performance of commissioning services insofar as they relate to patient experience, access and outcomes. People and Culture Committee, which is really a refresh of the People Committee, and that'll have an increased focus in that system role, particularly around workforce and obviously about ICB culture. And I think again, some of what we've heard more recently, a real focus on staff and well-being. The executive management team business meetings have been reviewed and will meet formally as an executive committee. The terms of reference for each of those committees are attached in full at Appendix A. 2 committees, Primary Care Commissioning Committee and the Public Involvement and Engagement Advisory Committee, are proposed to be disestablished, and these functions will be overseen on a day-to-day basis through the executive, with assurance reports to the 2 assuring committees or up to the board. To continue to ensure continued clear governance of primary care functions, a primary care contract subcommittee is going to be formed, and again that will report directly into the executive committee, but it will also have to provide assurance on both financial performance against contract and patient quality outcomes and experience through the quality and outcomes committee. In terms of public involvement and engagement, just to give assurance that again, through this review, I think what's been recognised is that we've now got really well embedded processes and mechanisms in place around patient involvement and engagement. So it's not to dilute that in any way. The oversight will sit within the executive, but Neil and the work that Neil leads and his team will continue you know, to have that representative from comms and engagement at relative meetings. They'll continue to have your regular meetings with Health Watch, voluntary sector and other key stakeholders, and that's all articulated in more detail in section 3 of the report. Strategic commissioning, and again recognising this was written before the announcement, the consideration has been given for a dedicated committee to be formed in Q2 of the next financial year. I think that'll need to be considered again, given, you know, once we're clearer on what's meant by the ICB being a strategic commissioner. Until that point, all current commissioning arrangements remain in place, and again they're all described within the report, and there will be no changes to the system or northwest-wide governance arrangements around delegated commissioning of specialised services. Section 4 highlights where associated governance documents have been updated. These are mostly administrative to reflect, you know, the terminology, title of the new committees. The only change to the scheme of delegation is now removing where the Primary Care Commissioning Committee could approve procurements up to the value of 10 million. That will now sit within the Executive Committee, and the Executive will obviously escalate to the board, you know, where needed. The timescales, so if this is approved today, timescales are to implement this new structure by not next week, following week, 1st of April 2025. Annual business plans will be agreed for each of the committees with the chairs and lead executives, and any changes to membership will be communicated to those individuals. There's some further development that we'll still need to do in Q1 to support the review. So there'll be a review of the BAF, and there's some work that the board will also do on that seminar in May. Integrated performance report, which was touched on earlier, will be developed over Q1 so that it's meaningful and insightful, and not only is it against national requirements, but it'll give us matrix against what we locally agree as our priorities. And the executives will undertake a comprehensive review of delivery oversight and decision-making groups and forums that will need to report into the executive committee to ensure that that's fully supported. Thank you for taking
Thank you.
questions.
Thank you, Deborah. Any questions for Deborah? Sakthi?
Very brief one. I mean, this is, although it might be a boring subject for some, I think it's an important one. I'm assuming that the statutory duties to cooperate with partner organisations, there are no changes, and therefore that's why they're not part of the paper.
No, absolutely
Thank
not.
you.
Absolutely
Because there's Health and Wellbeing
Important
Board
question.
and ICP.
Yeah,
and,
no, absolutely not.
yeah.
No, this is just the internal assurance. And I think the other thing I would say is I'm a believer in governance should reflect what you're trying to do. So we may well need to review this, and we will review it as often as we need to make sure we get it right. David?
Thank you. So thank you for the paper. It's, you know, I was pleased that the review is taking place. I am, however, left with a number of concerns, so I'll just kind of try and spell those out. I think we've heard repeatedly across the board agenda today just how important engagement is in a range of different places, and in fact the need for us to do much more of it. And I'm not sure that I agree that we've got robust engagement mechanisms in place. So I think that we need to, you know, have a think about that maybe. And the other part of that discussion was about the execs having oversight of the engagement plans. And again, I'm left uncomfortable by that because of the lack of independent scrutiny that allows for the public. You know, openness and transparency is absolutely paramount in the work of the ICB, and I think some of the plans that you've presented in the paper don't allow for that. So I'd just raise those points to be considered in any final decisions.
No, thank you, David. And I think I would agree with you on both. And I think what my primary thinking around the PIAC committee was that having it as a subcommittee of the board isn't good enough, and it needs to come to the board. So the quarterly insight report, I want to hear a lot more from Neil and indeed from you. I think some other ICBs have a report from Healthwatch, so I think we can perhaps take that offline. But my intention is that this reinforces the importance of engagement, but it absolutely not taking it away. So and you know, we can work together on that to make sure that we get it right. The precise format we may need to adapt over a period of time. Any other thoughts? No. Thank you very much, and yeah, thanks for the input. Right, we are being asked to approve this. I'm being metaphorically kicked in the shin. And I think, and I would return back to what I said. We approve it because I think it's in the right direction of travel. There may be tweaks along the way, and we will make those tweaks absolutely to make sure. And in fact, there may be some more than tweaks as we reorganise ourselves. But thank you. Can I ask the board to approve that? Thank you. And finally, we've got the report concerning matters considered in private board. And again, this is an important one because we have had a lot of private boards over the last couple of months because there's been a lot of work to be done. And I was keen that the public, what we discussed came to the public. So I'm just going to hand over to Deborah.
Thank you, Chair. So the report summarises key matters that the board has considered in its private board meeting since mid-January. It aims to provide both transparency and context in relation to the business that's considered, and hopefully the public can see that the vast majority of what is considered then translates into public board either discussions or decisions. There have been 6 meetings over this period, which is exceptional, and again it just reflects the current operating environment. So it's not that the board would normally do this much business in private. The report will be a standing item on the board agenda going forward, and would welcome any comments. Thank you.
Thank you, Deborah. Any thoughts? And I would second the thing. We are not planning to have that many board meetings. We'll all go spare. But there's been an awful lot to do. Everything in those meetings will come back to the public. I think there's nothing that we would discuss. It's about thrashing things out occasionally, where we've had quite a lot of progress to make. Any comments? No. Okay. So I think we are now coming to any other business. Does anybody have any other business? Yes, Debbie.
Thanks. I didn't want to disturb the flow when you were talking about the committee review and it being approved, but I just wanted, because I've chaired the Primary Care Commissioning Committee and also PIAC, I couldn't miss the opportunity just really to recognise and thank people, given that those structures won't be moving forward and things will be done in a different way. So I did want to thank in particular around Primary Care Craig and also Peter Tinson for the work and the support. And then also from PIAC's perspective, Neil and also David Rogers in particular, who've sort of underpinned that work. But also to thank, I know David, you've raised points to be considered, but I do want to thank Healthwatch for sitting around the table with us in PIAC and contributing. BCFS, trusts, place representatives and also representatives from the citizens panel who've sort of all come together through that committee to give that assurance. So I'm sure that work will continue, and as Emma said, it'll actually be escalated, so it's more directly viewed and cited by board, which will strengthen it moving forward.
Okay. Thank you, Debbie. Okay, thank you all very much. Long agenda again, but thank you for all the contributions, and look forward to seeing you in May.